Right back.
I'm trying to find the fruit snacks in the world of. I don't see it.
Now the prizes. For the costume contest. On that. That's neat. I want the whole thing. Oh, there it is. Morning. Let's have an envelope. Thank you. I appreciate it.
Let me just finish mine.
Exactly. Super happy.
I did.
Imagine she told me no.
You did it.
Literally, you're saying. Yeah, I'm saying, like, give me your car. Be like, I am your mother.
Like, your car is just sitting here.
It looks like a chunky baby. That's my baby. My last baby. She loves a chunky baby. I like when they got like the little thick sides and stuff. She was like 18.5 inches and almost 9 pounds. Oh my gosh. She looked like a baby sumo wrestler. Literally. At first, I was just like, why does it have my name on it? And I was just like, oh wait. No, it's your from winning.
The red bag. It's a red flag.
So on the 17th, we have what? I tried getting an appointment another day, but they were having mountains. Okay, but it's 9:20, so it only takes like 20 minutes. Okay. So I'll try it. Okay. Huh?
What did they do then for this?
We're gonna go over. We're gonna talk about it. Well, the baby too, yes. This baby is my baby. This is my last baby. She was a sumo baby.
Long fingernails.
Mm-hmm. And she was only 38 weeks.
See, the ones that like deliver early, but they're still 9 pounds, I'm like, in 2 weeks, how big would they would be?
Yeah.
She's so chubby.
Is it what? Weird what? Go ahead, say it, Joe.
Is it weird to want a baby?
Oh, weird to want a baby? No. They're so cute and precious. I'm just thankful I don't have a uterus anymore, so I can want one, but I can't have one.
Oh, no.
That's always nice.
But then when you're pushing, you're like,
No, he doesn't either. He'll have to find someone to love him and have a baby for him. Okay, I was waiting on Nellie, but I'll have to go over it with her. So, as of November 5th, CMS, which is the Center for Medicaid and Medicare Services, mandated that all healthcare facilities that receive CMS funding through Medicaid and Medicare must have employees, staff, students, anyone that has patient contact have to be vaccinated by January 4th. Okay? The college is not mandating it, but you just have to understand that the majority, all of our clinical sites are CMS funded. Therefore, in January, if you're not vaccinated and that clinical site requires you to be vaccinated and you cannot complete 50% of your clinicals in person, you will not pass the clinical portion of your last semester. Therefore, you will not be able to pass your last semester. Okay. So, like I said, the college is not mandating this, we're not requiring it. This is your choice. But just understand, for you to continue in the nursing program, more than likely you're going to have a COVID vaccine. Okay. So I just need you to sign that statement stating we talked about it. You understand that you've been notified that this is the guidelines and the potential that if you do not get vaccinated, that you may not be able to finish the program. This is not coming from us. This is coming from your federal government and the facilities that we are in. And even though your employer may not have notified you yet, just get ready. They're going to require your first vaccination be done by December 5th, and your second vaccination has to be done by January 4th. If you're employed by a facility that is CMS accredited or funded. And as of right now, depending on the facility, we do not know if there will be exemptions. I sent you out an email just a while ago that has the policies per CMS, the actual written out statement, and a question answer form. They're kind of leaving exemptions up to the facility themselves. But just remember, if you want to have an exemption for medical or religious reasons, it does not necessarily mean that the facility has to accept it. So, okay. So that's that. So you guys can read over it, sign it for me. I'll just gather it later in class. Another business. So I sent out an email yesterday stating that I'm going to add a third test. So we'll have a total of 4. So next Thursday on the 18th, we're going to have a test. 50% of your points will be from a case study that I'm going to send you Friday. You will be able to work on the case study at home alone. Okay, this is the honor system here. I want to trust that you yourself are using your own brain and resources and not your friends. Okay, because it's going to count for 50% of your grade. I'm going to do that on this next test and the test after that. If you complete the case study and follow the directions, you will get all your points. Okay. Does that sound good to everybody? Okay. Yes.
You're separating this content between two tests.
Yes, so fetal well-being today, postpartum tomorrow will be on the test on the 17th. The last test will only be newborn and newborn complications. So it probably won't be a very long test as far as your multiple choice questions, maybe 20 or 30, and same on your next test. Biggest portion will be your case study. Okay? Because everybody does test differently, and some people do better outside of multiple choice questions. And so I understand that, and so we're going to try that. Okay? And you will be able to use your resources for your case study, but just understand, because it is a case study outside of the class, it's going to be very detailed. Okay? I'm going to ask lots of detailed questions, and I want lots of good information. Okay? You have your book. We have other books here, resources here you can utilize. I'm okay with you using ACOG, A1 websites to find your information. Even Wikipedia if it's good. Please don't give me some random, because I will look up your resources, just gonna tell you, okay? Because this is a big deal for me to make the test like this. And so it's gonna take me time to grade it, but I just want to give you guys an opportunity to do well in this part, because maternity is hard for some people, because if you don't do it, you don't know it. And it's a lot of content you have to know, and it's content you've never learned before. So
Is this due on Thursday?
it will be due the day of the test. Yep. I will have a Dropbox for you to upload it by 8:30 that morning, and you'll upload it via PDF. Please don't send me a JPEG. A lot of you guys are sending JPEGs. Just remember, when you're sending in if you decide to go onto your BSN program, if you're sending in a paper that, yes, you may have handwritten, it has to be like a PDF form, okay? I don't want to see your comforter, don't want to see the bed linen. You can crop those if you use your scanner. You can, on an Apple phone, you can use Notes. Android, there's a program on there that you can scan it as a PDF, crop it, make it look like it's a document, and then send it to me. Okay.
Amanda, sorry, you said that fetal well-being and the postpartum at risk will be on Thursday.
We'll be on that Thursday test. Okay. I will also, other than do case study, I will do another not specific study guide, but I will add in some more Quizlets. Okay, because I know some of you like those to practice. And I'll put up the Quizlet again that has the fetal monitoring on it that I had. Did y'all go through that one? Because we will have more fetal monitoring on this next test, okay, because that's fetal well-being. I kind of gave you some basic stuff because we had kind of talked about a few things, but this will be more. And I'm not going to expect you to be a pro at reading it, okay? I'm going to give you some very basic strips for you to just give me some information on, okay? And there probably will be a little bit in the case study. We're kind of going to go from early labor to newborn, kind of, okay? Okay, so everybody's commented on this little chunky monkey. This is my chunky monkey. This is JC. She was my surprise baby, my midlife crisis. I was 35, decided I needed another one, tried for 1 month, and guess what? Had a baby. My husband was like, how did it happen so fast? I was like, I don't know. I think he was hoping it wouldn't, but he loves her. Her nickname is Monkey Bones. Okay, that's what my husband calls her, is Monkey Bones, or Monkey. And so when she was born, she weighed 8 pounds, 13 ounces. And the nurse measured her at about 20 inches, but my husband was like, that wasn't 20 inches. And so we measured her when we got home, and she was 18 and a half inches. So short and squatty, looked like a sumo baby. So just had to put her up there because she's super cute. Now she's 5 and a mess. I think she runs the roost. Okay, so fetal well-being takes up chapter 13 and 17 in your book. These are your learning outcomes. So we're going to talk about some antenatal testing. So this is mainly going to be talking about during that labor process. When we talk about some complications that can happen to mom in the last lecture. This is going to be about baby. Okay, how does baby react in those complications? Okay. So we can have some antenatal testing that we will do. Could be one test, could be a combination of tests. Most of the time you have your basic lab work, which is like a CDC, rubella, syphilis, hepatitis B antigen, your RH factor, your antibody screen to see if you have an antibody. And then a lot of these tests are going to be repeated throughout pregnancy, like about midway and then at delivery. So there's also some risk factors that we're looking for if we have a mom who is less than 16 or over 35. Okay. If you are over 35, you're a geriatric pregnancy. Your advanced maternal age. Okay, I have that on my chart. We also are looking for cervical insufficiency. Tell me, you guys have learned this, so tell me what can cause cervical insufficiency in a woman in pregnancy. Multiple births can be an indication. Also, nope. Nope. A biopsy, cervical biopsy. If you actually have tissue removed from that cervix itself, it's not going to be as strong. And so they're at bigger risk for cervical insufficiency. Okay.
Do you know how big of a risk? Because I feel like it's not even like.
That's a colpo. That's what you're thinking of. So colposcopy, yes, is where they just pinch off a little piece of tissue. A LEEP procedure or a cone procedure is where they actually remove a big portion of the cervix itself. Say they have the colposcopy done and it shows that there are abnormal cells. So you're going to take a big portion of that cervix out and they're going to send it off to pathology and they're going to do the margins like they would on any other type of cancerous cell. If they got it all, then it's good and they know that cervix can heal, but it's not going to regrow. You're just going to have scar tissue there. So I've seen some pretty big LEEP and cone procedures done where you take out an inch and a half.
So can you do a collage and just add that stitch in to like help the pregnancy?
The cerclage, yeah. And it does help for a lot of people, but, sometimes 34, 36 weeks, sometimes that cervix will start dilating and then they have to remove the cerclage. But hey, we've carried to 34, 36 versus 22, 24. Okay. We're going to look for hypertension disorders, diabetes, heart disease, that RH alloimmunization. That's where you have a RH negative mom, positive baby. Okay, this is only time we ever are concerned. Negative mom, positive baby. Okay. Mom has a history of stillbirth that increases her risk again. Intrauterine growth restriction, post dates, multiples, preterm labor history. So again, some common tests that we can see outside of those lab tests they're going to do are ultrasounds, amniocentesis, biophysical profiles, genetic screenings, non-stress tests, and contraction stress tests. On genetic screenings, years ago, we just had the MFASP, which was done around 12 weeks. That would look for 3 to 4 different trisomies and like a neural tube defect. Now we have some that can be done as early as 8 weeks. An 8-week one does not test for the neural tube defect, but it does test for other genetic anomalies and also can tell you the gender of the baby. So I knew with JC when I was about 10, 12 weeks pregnant that she was a girl because I had the harmony test because I was advanced maternal age. So when they first came out, a lot of the insurance companies would not cover that test unless it was medically necessary due to like AMA, history of some kind of congenital or genetic disorder. Now most insurance companies cover them at cost. You just have a copay you have to pay. Okay, so other antenatal testing we're gonna look at is maternal anxiety. Okay, how is mom gonna deal with these answers? Okay, say if she does have a test and something's wrong. Okay, she's gonna be anxious. She's gonna have lots of fear, especially if you get told early on something could potentially be wrong. Okay, so that's something you're gonna have to deal with almost through that whole pregnancy. So what is our job as a nurse? We've got to educate, help decrease that anxiety, provide clarity to mom. Okay, physician's going to be the one that gets the initial diagnosis and explanation, but you're going to have to come behind a lot of times and give further education and further information. Okay, so you yourself have to know what these problems are. Emotional support and help alleviate fear as much as you can. Never give false hope. Okay, But you can still be positive and give in that spirit of, okay, let's look and see what are the potentials, what are your risk factors, what is the percentage of this possibility actually being true, okay? So fetal activity. So the maternal assessment of fetal activity is non-invasive. It's an inexpensive procedure which the pregnant mom can identify if the fetal movements is occurring. So this is like your kit count, okay? So the fetal movement is directly related to a sleep-wake cycle. So babies do sleep for a period, okay? 2 to 3 hours sometimes. So there's the fetal movement record, which is the card off count to 10 or the kit count. It's non-invasive. If you have a reduction in fetal movement, it could be related to fetal hypoxia, fetal growth restriction, or possibly fetal death. It may decrease perinatal mortality. So if you have a mom who has a higher risk, you're going to educate them on those kit counts, especially if they're not feeling baby move. And this will help decrease that maternal anxiety. We're like, okay, baby's not moving. Because a lot of times what happens is they're up moving around doing stuff in the day, and you're not going to be as aware of when baby moves. And so they're like, oh my gosh, has the baby moved in a couple of hours? And so they're going to call you. And you're going to be like, okay, drink something sweet, eat something sweet, lay down on your left side. The first movement you feel, look at the clock. The fifth movement you feel, look at the clock. If it's been less than an hour, you're good. Okay. So you want 5 to 10 movements in an hour period. So you just have to teach mom how to monitor this. And so there's multiple tools now that we have apps on your phone where you can record kit counts. There's printouts that you can give to mom that she can record it on. But the main thing is that she understands that it's small movements, big movements, both count the same. If it's a movement, no matter what. Okay. So at 27 weeks is when we can start doing this. We may, if they're having issues that we're having to follow, we're going to have them do this at the same time every day. 1 hour after a meal, or have her eat a snack, something that's sugary, that's going to wake that baby up. Okay. Sideline, preferably left. Why left? Decreases pressure on the vena cava, opens up those major vessels, allows baby to get the best blood flow. You're going to do it sometimes up to 3 times a day, 20 to 30 minutes each. If they have 10 movements in less than 3 hours, or 10 movements within that 3 hours, you're good. But if you don't have those 10 movements, then you're going to call a doctor. I say 5 to 10 in an hour, because you should have 5 to 10 in an hour with a healthy baby. Okay. And I just do that because of my history. Having a stillbirth myself, I don't want ever anybody to be concerned and then, wait 3 hours when they needed to come in. I don't know if my baby kicked out. Let's try to. Just make it up like it did last time. So if you go back to your slide in the PowerPoint and click on the link, it's going to take you to a page that shows you an app that's designed for baby kit count. Okay. So ultrasounds. So these are high frequency sound waves that produce an image. Okay. Do you know if there's a limited amount or a limit of how many times you can have an ultrasound in pregnancy that you're supposed to relate it to the ultrasound risks? No, how many can you have without putting risks on baby? Are ultrasounds risky? The frequency can cause hearing loss. So if you have repetitive ultrasounds, you can actually cause hearing loss in the baby. Now, risk to benefit. If you have a baby that's high risk and you're having to monitor growth, or you're having to monitor a tumor or whatever, twins, you're having to monitor more often, risk to benefit. Okay, it's more beneficial to have multiple ultrasounds and see and take that small risk that one of the babies or the baby could have a hearing loss.
What is the likelihood of it?
I don't remember the exact percentage. It's pretty small, but it's still a risk. And so you have to explain that to moms if they're having multiple ultrasounds. Just understand that there is a risk because you're using sound waves, and it could damage as those inner ear bones are forming and growing. you can cause damage.
Is there a number or is it just? the more-
Usually most of the time they say 2 or less in pregnancy. That's kind of what insurance covers anyways, but 2 or less, you want to do a gross, or you want to do a dating ultrasound at the beginning, 8 to 12 weeks, because we're going to do that crown to rump length. And then again, around 24 to 26 weeks for a growth or anatomy scan. Okay. So transabdominal is one way, then that's where they actually go through the abdominal tissue. Okay. If you have a mom who is kind of bigger, plus size, has more adipose tissue, you can actually skew the results of a crown to rump measurement. Okay. And have her dates off. So it's better in those early stages to do a transvaginal ultrasound. Okay. You're going to be able to see better. There's less tissue for those sound waves to pass through. It's going to be more accurate with reading that crown to rump. Okay. So the reason we do these ultrasounds, one is we need to see, do we have a gestational sac? Okay. If you have an early HCG that's not measuring very high, we want to look and see, can we see that yolk sac and that fetal pole? If we can't see it yet, then we're going to have her repeat her HCG hormone levels, see if it's going up. If it doesn't go up, that means that baby's not growing, and we're going to repeat that ultrasound in a week. Okay. Sometimes you can have what's called a blighted ovum. So you actually have an egg that's fertilized, but then nothing ever happens. Okay. It's just basically an empty ovum. And you'll still have HCG hormones slightly increasing, but it's not going to increase at the rate as if it was a living baby. You're going to do that crown to rump length early on. Okay, that is where they actually measure from the top of the baby's head to the butt. Because remember, they're kind of in a C shape at that point. Got just little feet and leg poles, little feet and leg arms. Okay, that crown to rump measurement is actually going to give us an accurate dating. Okay, so anyone who has an ultrasound after the 12 weeks, they're more likely to be inaccurate. So most rule of thumb for physicians is if you have no ultrasound until 18 to 20 weeks or so after that 12-week window, if the baby measures 7 days or more, it's bigger by 7 days or more, they'll change the due date. If the baby falls within that 7-day window of measurement, you're going to keep the due date the same. Okay. So I wish physicians would be more honest with their patients about this, because, you know, they'll go in and have an ultrasound and, you know, baby's due November 25th. Then they'll go in and have, and that's the crown to rump, so that's the most accurate. Then they'll maybe go in at 12 weeks, because sometimes we would do a 12-week ultrasound, because it would also give us an idea with the MFASP, we could look at the roll on the neck to see if there was a thicker roll. That would be some indication of Downs and several other things you can scan at 12 weeks. So then they would go at 12 weeks and they would give them a due date of November 23rd. Well, it's still within that 7 days, so we're not going to change it, right? And then they would go to their anatomy scan and it's November 19th. So now this mom comes to you when she's due or having, you know, in labor, and she's like, you know, and you're like, okay, what's your due date? Well, first they told me it was November 25th, but the last ultrasound was November 19th. Well, then I have to explain to them. We go by that first ultrasound because it's most accurate, because the baby's small enough to where we can accurately measure. Once you get past that 12 weeks, and genetics can play a role. Okay. You're going to have babies with longer femurs and shorter femurs, and they take a different measurements of the baby, like the head, the femur length, the arm length. And that's what, you know, tells us the gestational age. Okay. So after they get past that early stages, genetics play a role. You got taller moms, taller dads, shorter dads. And so that's going to play a role in baby's measurements. Okay. Cardiac activity, we want to see that heart beating. Okay. Can anybody tell me when the heart starts beating? I heard 21 days, about 5 to 6 weeks. Okay. 5 to 6 week window, you're going to see that heart beating. Okay. We also are going to do ultrasounds to assess for possibility of multiples. Say she goes in and the doctor does a hemoglobin A1C, or not hemoglobin, HCG, sorry guys, an HCG, that human chorionic growth hormone. If it's really high and she's only supposed to be like 8 weeks, and that doctor's going to think, okay, one of two things possibly. What would it be? Molar pregnancy, or I guess 3 things. Further along, I heard that, or multiples. Okay, because you're making more HCG because you have more than one baby. Okay. The other thing with the transvaginal that we're going to look at is they're going to measure that cervical length. If we can get a cervical length early on, that is within the normal parameters, then we know she's at a smaller risk of having an incompetent cervix. If you have an early ultrasound and that cervix is already short, then they're gonna have repeat ultrasounds early on to make sure that cervix doesn't become shorter and shorter and shorter. Because if that cervix gets shorter and shorter and shorter and thinning out, then baby's going to deliver early. Okay. So can anybody else think of why we might do an ultrasound? Okay, uterine problems. Maybe we just need to see if there's any growth, huh? If they're having bleeding, right? We're going to look and see, we're bleeding, so now do we still have a viable fetus? What about late pregnancy? What's another reason we might do a scan real quick?
If it's breached.
Right, position. Maybe we can't really feel that baby's really high up. You can't really assess where that head is. And so we want to make sure baby's in a cephalic position, not breech. Okay. So when a mom goes in to have her ultrasound done, all you moms who've gone in, what is the first thing they tell you? Drink lots of water and have a full bladder. Why that? So it can push that uterus up into the abdomen if they're going to do a transabdominal. Okay. When I went in with my ultrasound with Abigail, my second child, because everything that happened with my first, I was very anxious, so I had drank and drank and drank on the way there, and I get there and all she could see was my bladder. And she was like, I need you to go pee a little bit, but don't pee everything out. So here I'm in the bathroom, like, okay, stop. Can I stop? Anyways, it was rather funny. Right, abdominal. Transvaginal, you don't have to have a whole bladder. But some physicians, it just depends. You don't know till you get there what's ordered. So that's why they tell you to go ahead. Yeah.
I only need 30 ounces.
30 ounces. Well, I had more than 30 that day. So the transvaginal, they're going to do, you don't necessarily have to have a super full bladder, but abdominal you do because it's going to push that uterus up into the abdominal cavity. Okay. So someone had said molar pregnancy. Some other things we might look for is if she's having some maybe side pain, one side or the other, what could that indicate? Ectopic. Maybe that baby's not in the uterine cavity. It's actually in the fallopian tube or on the ovary. Sometimes we need to look and see if we have enough fluid or we have too much fluid. Okay, that's another reason they may do a scan, is to see what the fluid level is. And they're going to actually measure pockets. They're going to go through and use a little tool that you put on the wall of the uterus and you put against the baby, and you're going to measure that pocket of fluid that's between those two things. And they're going to do that all around baby. And if you have greater than a certain amount, then you're within normal limits. If you have greater than that, you're polyhydramnios or hydramnios. Okay. So first trimester assessments of fetal well-being. So potential for the pregnancy to produce a live infant, we need to make sure that the actual pregnancy is a live infant. Okay. We have more pregnancies that occur than we realize. And the reason is because she may be only laid a day or two, and then all of a sudden she has a period. And so we probably had conception. Her body did start producing a little bit of HCG hormone, but then it never implanted the way it was supposed to. And so then she started her period. Okay. If you look to see what conditions your body has to be in to get pregnant, you'll be like, how does anybody ever get pregnant? I mean, it has to be the exact right conditions. It's the most amazing thing in the world. Okay. HCG will indicate that there's a pregnancy. That's the only time, except one other incidence, which is a type of female cancer, that you ever develop the HCG hormone. The other type of cancer is that choriocarcinoma or carcinoma. Okay. So HCG is only formed in pregnancy. So they're going to do a beta HCG at 8 to 11 days. Now, when is that 8 to 11 days from? Ovulation. Okay, that's why you can tell earlier and earlier and earlier on pregnancy tests because they, the initial pregnancy test years ago, you had to have, over 150 parts per million of HCG. Now it's like 40. I mean, it's very minimal. So that's why you can do those early pregnancy tests, 2 days, 3 days before your missed period and actually see, because it actually measures those, micro amounts of HCG in your urine. So it doubles every 48 hours for the first 10 days, and the peak number is 60 to 90 days. And I could give you a range, but let me tell you, the range is so broad. Okay, it's like, 1,000 to like hundreds of millions or hundreds of thousands, and that's normal. So it just depends on the person. We just know the higher that we see, the more likely that there's potential of twins, triplets, or we need to assess for molar pregnancies. In early pregnancy, you're going to do 2 quantitative beta HCG levels drawn 2 days apart to determine if that pregnancy is viable. And we're only going to do this if we have some complications going on. Okay. If it's a normal healthy pregnancy, your doctor's not going to do an HCG level. They would do it if maybe you have some prior miscarriages, you have bleeding in this pregnancy, maybe some severe abdominal pain more so than just normal cramping. You're going to have an indication why you would do this. In contrast, if it falls over 48 hours, so instead of going up after 48 hours, it comes down, then we know that there's a big risk for miscarriage or ectopic pregnancy. Okay, so if it doesn't double in that 48 hours but drops, then we know we're at risk. We may perform in women who are spotting to determine levels, have a history of ectopic pregnancy or spontaneous abortions. We may also do a progesterone level. Low levels can indicate miscarriage. Okay, a lot of women who have recurrent miscarriages tend to have lower levels of progesterone. That progesterone is secreted early by the corpus luteum. Important to know. So before your placenta begins to make its own progesterone, that corpus luteum, which is part of what that baby is, produces that progesterone. So low levels are associated with ectopic or miscarriages. We don't routinely test women for the progesterone level unless they have a history of those 2 things. It should be 25 or greater in a normal pregnancy. If it's below 5, then we know the pregnancy is not viable.
You said corpus luteum produces progesterone prior to pregnancy?
Prior to the placenta. So the corpus luteum is part of that process from conception to actual embryo. Okay. And so once you have fertilization and that corpus luteum starts to form, then you're going to have progesterone being produced by it until the placenta takes over, because the placenta has to grow and develop. Okay. So level of 25 or greater is normal, 5 or less is abnormal and more than likely not viable. So we can give progesterone supplements to help prolong an inevitable non-viable pregnancy. Hopefully it will help sustain for 12 weeks once that placenta takes over. Okay. Usually once you have a woman start progesterone, she's not going to stop it. Okay, because we don't want those levels to drop. There's 3 ways you can take it. The 2 best ways are vaginal. We'll make vaginal suppositories that the woman will put up in the body to the cervix, and that will absorb that progesterone directly to where baby is, or IM. Okay, IM progesterone is thick. It's as thick as peanut butter. I hated giving IM progesterone in the clinic. Just super thick. Okay, and so, but if it's going to help maintain your pregnancy, then let's do it. Okay.
Is that legitimately IM or?
Legitimately IM.
Because like sometimes I feel like, what's it called? Lovenox?
Mhm.
Always give it in the fatty part.
Right, that's sub-Q.
When other places we can do it in the arm too.
Yeah, you can do it in the abdomen or the back of the arm. You just need to make sure it's in the fatty tissue.
Yeah.
So with the progesterone, yes, you need a muscle and you want a large muscle. You will not do it in the arm. You're going to do it here or the leg.
Because I only say that because I feel like everyone always goes with low enough always in the fatty part and the bottom never
to the back of the arm, like insulin. And because per protocol, when we first started doing Lovenox, we always did it in the abdomen, but you can do it in the back of the arm as long as you're giving it sub-Q into that fatty tissue. But with the progesterone, it is IM. You want to go into that muscle.
Before I had left working the clinic, they started doing the sub-Q progesterone.
Oh, really? That's
They would
neat.
use like a auto injector.
Oh, really? Yes, because have you ever given progesterone oil? Oh, my Lord. It's like peanut butter. I'm telling you, it is the hardest thing to give. And you're not just giving like 1 cc, you're giving like 3 cc's.
And then like when we used to give them like the IM ones was from week, I think it was like 16 all the way
To 36. Yep. Mhm.
So every week.
Mhm. Yep. Yep.
What gauge of needle do you use for that?
You're going to use a larger. You're going to use like, no, you wouldn't use that big, but you're going to use like a 22, 20. Yeah. 20 is usually what I would use. Okay. So gestational age. We need to determine the most accurate expected due date. Okay. EDC, so estimated date of confinement. So years ago when women had babies or got closer to term and were showing, they were put into confinement because it was taboo to be seen with a belly because you knew what you did. Like, well, how do they have babies? So confinement. So, and women would literally then after baby was born, stay in bed like 5 to 10 days. Okay. We wonder why a lot of women died years ago because they had this idea that helped the body heal. So EDC is estimated date of confinement or EDV, estimated date of birth. Okay. So you're going to see it several different ways. Traditional way of determining the estimated date of birth is by the last menstrual period, measuring the uterine size, or noting the first audible fetal heart rate, or the date mom starts feeling baby move. Can somebody tell me when we use the LMP, what is the rule we use? Nagel's rule. Yeah. Can somebody tell me how we measure that? Yep, minus 3 months plus 7 days. Probably a good thing to know.
The start or the last day of the period?
Last menstrual period, so the very first day. So it's the start of the last menstrual period. Okay, the first day of your last period is how you say it. Can you tell me the first day? Huh? When you subtract 3, Nagel's rule. It's Naegels, I think. So quickening. Quickening, does anybody know what that means? Quickening. First fetal movement. I'm just going to keep listening to her because she's the loudest. Y'all got to talk. I can't hear. I'm deaf, people. I listened to my daddy play the drums when I was little in the garage, all locked in there and nothing on my ears. Okay. So, yes, quickening, the first fetal movement. A lot of women don't realize at first what it is because it kind of feels like gas. Okay. I remember after having my first baby and feeling gas move through my stomach, I was like, oh my gosh, am I pregnant again? I mean, because it really kind of has that same sensation of that butterfly like sensation. So a lot of women just think, oh, I must be gassy. Because when you're pregnant, you are, and then it keeps going on and gets a little stronger over a few days. And you're like, oh, I think that's the baby moving. Can anybody tell me the average time you're going to feel a baby move? 16 is about the earliest, okay? 15 to 16. If they haven't felt baby move by 20 weeks, they need to let the doctor know, okay? Because then we need to assess, do we possibly have a spinal tube defect?
So like when I first felt my daughter, she was like 3 months.
Yeah, there are some people who are real in tune with their body and can start feeling baby move 13, 14 weeks. It's not as common, but there are some people who can. If you if you're real in tune, my sister-in-law was the same way. She could feel all her babies around 13 weeks, but not everybody can. It just depends, one, where placenta is located. Because if your placenta is on the anterior side of your uterus, then as they kick into it, you're not going to have as much sensation in your abdominal muscle and tissue because first it's being impacted into that placenta. But if it's at the top of your fundus or at the back of your uterus, then you're going to have more of that frontal sensation. Or if they're turned where they're facing backwards and kicking into that placenta, you may not feel it as early. And we don't suggest doing kick counts early because until about 27, 28 weeks, depending on size of baby, position of baby, you're not always going to feel movement all the time. As they grow is when you're going to feel it more often. So the crown to rump length, again, is done by sonogram. It is the most accurate way to assess for gestational age. Hint, hint. Should be performed between 6 to 12 weeks for the most accurate, okay? And you're probably going to have plus or minus 3 to 5 days, but that 3 to 5 day window is not going to affect baby. Again, it's less accurate after 12 weeks. Greater than 26-week growth rates are not as uniform because, again, of genetics.
After how many weeks?
26 weeks. After 26 weeks, it's not going to be as accurate. Still, really, after 12, I mean, it can be somewhat accurate. At least it's going to be better at 16 weeks versus 26 weeks. Okay. It's very extremely important to estimate that estimated birth date or due date early on, okay? Because we know that even a difference of 7 to 14 days can make a big difference in baby, either way, okay? Early or late. So genetic screening in the first trimester that we're gonna see, we're gonna have ultrasound and serum screening tests. The nuchal translucency, that's what I was talking about, where they measure the fat pad at the back of the baby's neck at 12 weeks. That can be an indicator of Down syndrome, okay? Not all facilities or physicians utilize this unless you have an abnormal ASP, and then they'll go in and measure that. Then they'll do the plasma protein A and free beta HCG, so that plasma protein A is part of that MFASP. This tests for Down syndrome, which is trisomy 21, trisomy 13, and trisomy 18. So then once you have your positive blood screen, then you're going to go in and have an ultrasound to perform that nuchal translucency test and look at those nuchal folds. It looks at the amount of fluid between the posterior cervical spine and those nuchal folds. So if it's increased and thicker, then we know that there's a higher risk of Downs. Using this combined screening for the type of testing gives 91 to 98% accuracy in detecting Downs and trisomy 18. So it's pretty accurate. It is not common to see the nuchal translucency performed alone at the 11 to 13 weeks unless you have that positive test. And sometimes you can have false positives, and so that's why they do that ultrasound to measure that nuchal translucency.
All the trisomies or just the 21?
21 and 18 are the ones that nuchal translucency will give you.
Is there one that's worse than the other?
13, yes. Trisomy 21, of course, we know those people can live to old age. Down syndrome, one of the doctors that I worked with and went to church with in Mena, Arkansas, had a daughter who had Downs, and she was the sweetest little girl. I mean, she was like 23, but she was the best. Trisomy 18 can live past into older age. Of course, there's lots of complications. Trisomy 13 is pretty much incompatible. So Doppler flow studies, this is where we're actually looking at the actual cord itself, okay, and the placenta. The Doppler flow study or the umbilical velocimetry can be done between 26 weeks and term, okay? And you're looking for how many vessels in the cord, okay, 2, arteries and one vein. Okay. So if we only see two, 1 and 1, then we know they're a higher risk of stillbirth and other fetal anomalies. So an ultrasound is used to measure the blood flow changes between maternal and fetal circulation to assess that placental function. It measures the systolic versus the diastolic flow, a ratio through the umbilical cord. So elevations of greater than 3 are considered abnormal. So it measures the fetal cardiac output, and it's used when suspected uteroplacental insufficiency is there, okay? When you have the IUGR, we know that probably that placenta is not working appropriately because baby's not able to grow because it's not getting the blood flow nutrition it needs. We may not know the cause of the uteroplacental insufficiency, but we know it can be related to hypertension and preeclampsia. That's your most common cause. And smoking. But smoking causes vasoconstriction, which decreases blood flow. Non-stress test. So this is one of the important things as a nurse outside of OB that you do need to kind of know about, okay? So say you're working in the ER, you have a 32-weeker that comes in that's been in an automobile accident. I've been a labor nurse on the floor here at Southwest Med. I got a call, said, hey, can you bring a monitor down? We have a 32-weeker who just came in. She was in a bumper to bumper. Can you come do a non-stress test? So I had to go down, put her on the monitor while they're doing all their stuff to assess baby, okay? So there's a chance you may at some point have to assist in doing a non-stress test, okay? So what we're looking for is adequate oxygenation and that the central nervous system is intact, that it's working appropriately. The central nervous system is most mature between 30 to 32 weeks. Okay. This is going to give us an idea of fetal well-being and oxygenation. So if I give you a test question, what is an NST an indicator of? Fetal well-being, good oxygenation. Okay. If you have a good NST, you have a reactive strip with accelerations, then you know that baby's good. That baby's happy, it's getting enough oxygen. You should see fetal accelerations, and an acceleration has to be 15 beats by 15 seconds above your baseline. So if you have a baseline of 120 and it goes to 130 and it only lasts 10 seconds, is that an acceleration? Not for a term baby, okay? Preterm, yes, because it's 10 by 10. But a term, it's 15 seconds by 15 beats, okay?
For how long did you say?
It has to be 15 seconds long and 15 beats high above the baseline. And you're going to look over a 10-minute period. Okay. Most NSTs are 20 minutes. Sometimes we leave them on for an hour. But after 20 minutes, if you see a NST that has good accelerations, you have at least 2 accelerations in that period, no decels, and good variability, you know baby's good. And that's a reactive NST. You have to have 2 accelerations in 20 minutes, 15 by 15, to be a reactive NST.
Just 2 in 20 minutes?
Just 2 and 20. Okay. A non-reactive strip means what? Possible D cells, or maybe I don't have any A cells and my variability is okay, but I don't have any A cells. Okay. If I have good variability and I don't have any A cells, more than likely that baby's asleep and I need to go wake it up so I can get my A cells and I can get her out there. Okay. Because she wants to go home. I don't need her there where baby looks good. Okay. But if I have her on the monitor and I have no variability, like we had yesterday, and we're going to talk more about this in a minute. If you have a flat line asystole look, that's no variability, okay? Minimal variability is where it just falls. Here's your 10 beat block, okay? It has to be less than 6 beats, so it's got to be pretty minimal. but it's not flat line. So there is some variation in that line, okay? Moderate's where you're gonna be outside of that 10 beat block, okay? Because anything greater than 6 beats, less than 25 beats is moderate, okay? Anything above that's marked. And that's gonna kind of have more of that sawtooth look, okay? And we'll talk about that a little bit later also. So associated risk factors with why we would do a non-stress test, okay? If mom has diabetes mellitus, she has preeclampsia, you suspect intrauterine growth restriction, or you have multiples. They can cause decline in that uteroplacental function, leading to a decrease in oxygen to the baby, causing asphyxia possibly. Some doctors will do this twice a week. Some doctors will do it once a week if you have a high-risk mom, okay, depending on what the issue's going on. So the procedure that you're going to see, we got to put them in a position. So the best position for an NST is going to be kind of semi-fowlers. You want to do side or semi-fowlers. If you do semi-fowlers on their back, you want to do like a pillow on that left side to kind of displace that uterine cavity. Okay, because we want to, or I mean on the right side, so it's displaced to the left, so that way we have that vena cava flow at the best. Okay, because sometimes it's hard on the smaller babies, you know, at 32, 33 weeks to keep them on the monitor when they're on their side. But if they're going to keep them on their back, then, you know, displace that uterus a little bit. Okay. You're going to connect the fetal monitor. We're going to do about a 20 to 30 minute strip. You're going to give the mom a little clicker. So all of our monitors at the hospital here have these cords that connect to them, and it has a button. Okay. And if you're doing an accurate non-stress test, then what you're going to do is you're going to have mom click that button every time she feels the baby move, okay, within that 20 to 30 minutes. And you want to look at movement associated with acceleration, okay? So it's going to put a little tick, like a little line at the bottom of your monitor strip. So when you see that little line, you can look, okay, did baby have A cells? If baby had A cells, baby's good. Baby's reacting to its movement. Baby doesn't have A cells, then we got to look and see what could be going on. So how do we interpret the NST? So we want a reactive. Reactive is good. Okay. However, you need to remember that. Reactive is good. You're going to have 2 or more accelerations with fetal movement in that 20-minute period. And they have to be 15 by 15 beats from the baseline. Non-reactive means lack of insufficient acceleration. So we don't have any A cells, maybe 1, okay? And what we're probably gonna do after that 20, 30 minutes, if we don't have a reactive strip, we're gonna keep her on for a little longer, see if we can make baby reactive. Give her some orange juice with sugar in it. We actually have these little vibrator pieces that come with your monitor that you go up and you put it on the mom's belly and you push the button and it goes, wakes the baby up. Or sometimes you just take your hands and wobble her belly back and forth. Whatever you can to make that baby wake up.
You could only do it 3 times.
What?
Shaking.
Yes. Yeah. You don't want to do it too much because you don't want to cause other issues with word or anything like that. So yes, you only want to do it so many times. If you don't get a reaction after the first or second time, baby's not going to react.
Would that be a non-stress test then if you're doing?
Hmm?
Would that really be a non-stress test then if you're like stressing them all?
Well, the stress test is where you're actually contracting. You're making her contract. And we're going to talk about that in a second. And so think about the difference of an actual contraction where the uterus is completely contracting around that baby versus me just going in and kind of pushing on it. Okay. You're not really causing stress. You know, you're just agitating. Now, I don't want you to go in and like, okay, we're just talking about poking a little bit. Like, come on, baby, wake up. Okay. Maybe don't go abuse that belly. Okay. So if we don't have a good stress test within that 20-minute window, we're going to keep monitoring. If we still can't get it, then guess what? She's probably going to be staying with you Probably gonna be giving her some fluids, you're probably gonna be, you know, getting an ultrasound, a biophysical profile, look at that placenta, look at baby, okay? Unsatisfactory NST is where you have maybe a baby that's moving so much and you can't keep that fetal heart rate up on the strip, so you got breaks in it. You can't assess that. If you have breaks in your strip, you can't assess it, okay? So then you're gonna have to reposition your Doppler on mom's belly, so that way you can get heart rate better and monitor again, okay? So if anybody ever has a strip that's got big chunks of heart rate missing and they're like, oh, that's a reactive strip, be like, how can you tell that? You're missing 5 minutes right there. What's that baby had a decel there? Okay, so you have to have an accurate, continuous strip. Or maybe you don't have enough fetal activity, baby's not moving enough with mom. And sometimes it's just a misunderstanding. Mom's not understanding that those small and big movements count. They're thinking like major kick. You know, baby just kind of moves, rolls to the side. They feel a small sensation. They're not clicking the button. That's why we have to explain to them small movements, big movements, all count the same. So here are some A cells. Okay, this is a nice, pretty strip. This is one that everybody wants to see. They come in, you put the lady on the monitor, it looks like this for 20 minutes. We're good. Baby's good, mom's good. Do you see any contractions?
No.
No. So on this strip, we don't have the little ticks, but you can actually see, a lot of times you'll see this when you're looking at the fetal strip. When you have these little spikes up, this is fetal movement. Because remember, that's just pressure, that toco is sensing pressure. So if baby's putting pressure up against that toco, it's going to record it. So when you see these little spikes up like this, that's fetal movement. So if we have a fetal movement here, and I have an A cell, is that good?
Yes.
Very good. Baby's reacting to its movement. Okay, heart rate's going up. So this is a beautiful, beautiful strip. Okay. The next strip is a non-stress test that's non-reactive. Okay. So on this one, I can see some fetal movements again. But when I look where my fetal movement was, do I have an A cell? I don't have an A cell, right? So that means that the sorry, Christy, I haven't been sharing my screen. That means that baby is moving but not reacting. Okay. So what is our nursing responsibility when we're doing this NST? Okay, we are the ones who are going to be putting the monitors on. So how am I going to know where to put that Doppler to find baby's heart rate best? What am I going to do?
Leopold position.
Field position, what's that called? Leopold. Okay, going to start at the top, work my way down on both sides. Okay, then I'm going to feel to see if I feel the head. If I feel the head, if I know where the back is, that's where I'm going to put that Doppler to get the heart rate. Okay, that's going to be the best location for that ultrasound to go for me to find that baby's heart rate. Okay, we're going to get a set of vital signs when they get there before they leave. We're going to give instructions to the patients on how to use our little clicker if we're monitoring fetal movement. And then we have to actually interpret the strip. It is our job to look at that and then call the physician and say, hey, it's a reactive non-stress test. Okay. Does that seem a little scary? It can be. That's when you have to have experience or have a good experienced person there with you. Okay. Reading fetal monitor strips are not hard, but because a reactive strip that's good, anybody can almost tell. Oh, that's perfect. Okay. But when you kind of have those borderline ones where you're like, is that a late decel? Is that an early? Variables you can see easily, but sometimes those earlys and lates are very subtle and you can't. But you have to interpret the strip. And then you're going to report the findings to the provider because the patient's going to come to you on the floor. You're going to do your NST for 20, 30 minutes, call a physician and say, hey, we have a reactive strip. This is her blood pressure. Vital signs are good. No complaints. And they're going to go, okay, send her home. And you're going to have her scheduled again for next week or Monday and Friday or whatever, okay? Let's take a break. 9:30, be back here at 9:50. If you take the test and you pass it,
Like, I don't know when you're waiting for like.
I can't remember what the term is, but my husband's aunt was the same way. She had a bachelor's degree, but she passed it. So she passed the test. Okay, let's keep talking about this lovely baby fetal well-being. Okay. So we kind of talked about already how we can stimulate the baby to try to make it move. So it actually has a name. It's fetal acoustic or vibroacoustic stimulation. Can be used to assist the non-reactive NST, helps decrease that NST time that you're having to keep her on. So it's an actual device that you take, put on mom's belly, and it has a low frequency vibration or buzzing noise. Okay, kind of wake baby up. How would you like somebody to come do that to you in the middle of the night? Put something on you. Go, okay, so it induces that fetal movement. You can do it in 1 minute intervals, and really you don't even need, I mean, you're just gonna put it on there for a few seconds and then you're gonna do it up to 3 times every minute, okay, for three times. Again, we don't want to overstress baby, so we're not gonna do it more than that. Usually after the first or second time, you're gonna notice a difference. You're gonna see baby react. So another test that we do besides the NST is called a biophysical profile, or you will actually see this as a BPP. So if you have a question on the test that has BPP, that means a biophysical profile. Okay. So it's the use of a non-stress test and an ultrasound combined. You're going to use both results to tell if this baby's good. So you assess 5 fetal biophysical variables. Okay. Fetal heart rate for A cells, which is the NST. On the ultrasound, they're going to look for fetal breathing. Okay, baby actually practice breathes once it's close to term. Fetal body and limb movements, how well is baby moving? Okay. Fetal tone, so extension and flexion of the extremities. So you're going to look at baby actually moving their arms or even extending their neck. Same with their legs. And then you're going to look at that amniotic fluid volume. Okay. You need to have a pocket greater than 5 centimeters. Then we know there's enough fluid. Yes.
And this is now what week?
This is going to be like close to term, 36, 37 weeks, biophysical profile. Because you've got to be late enough in the term to where you can actually see those breathing movements. Okay.
You said the pocket greater than 5 centimeters
Mhm.
to know that there's enough fluid.
Mhm.
And how much is too much fluid?
I think it's 15 to 20, but I'll have to double check. I can't say 100%. It's been a long time.
And
I
then you said how many weeks? Like usually.
Around 30, 36, 37, 35 to 37 in there. Okay, because I need to be actually, and the biophysical profile, if you do before that, is not going to give us any indications of how well baby's doing because it's not doing those breathing movements yet. It's not
for preterm.
right. Yeah. So then we're going to do with the fluid volume, we of course we're assessing to see, and each one of these there's a score. Okay, they're going to get so many points for each one out of 10. I'm not going to require you to know what each one scored at. Okay, because you're not going to be the one doing the scoring. It's going to be the ultrasound person puts all the information in and it scores it. Okay. So if you have anything greater, so if you get a biophysical of a 2, that's bad. You don't have very many of those things happening. Most of the time you're going to see about a 7 to 8. That's good. Okay. Because each one gets scored a different number. And then sometimes we can have a modified BPP where we're just doing the non-stress test and we're doing the amniotic fluid volume. Okay, we're just looking at the AFI.
Is it not the ultrasound?
It's still an ultrasound, but you're not measuring breathing, you're not measuring movements of baby, you're just measuring the fluid pockets.
For decreased fetal movement, do they develop or NSTs?
Usually with decreased fetal movement, you're gonna do an NST. If it's reactive, then you're not gonna do a BPP. If it's non-reactive, they're probably gonna do a BPP, unless you have other indicators. Yeah. And it just depends on the provider too, you know. So if we need to look at that AFI, that amniotic fluid index or volume, because that's going to tell us if those kidneys are functioning properly, because remember babies are swallowing the amniotic fluid, peeing it back out, swallowing the amniotic fluid, peeing it back out. Okay. So if our amniotic fluid volume is getting lower and lower, then that means baby could possibly have some kidney disorders and it's not able to void the urine back out. Okay. And it's going to be indicative of an intact central nervous system. So in your book on page 259, there's a table that gives you the criteria for scoring the BPP. So it'll actually show you in there what the scoring process is. But again, you don't have to know how to score a BPP.
259.
259, yep. So why would we need to do a BPP? So this is whenever there is a risk for placental insufficiency or fetal compromise. So you're looking at diabetes, chronic hypertension, sickle cell anemia, history of stillbirth, non-reactive NST, renal disease in the baby, hyperthyroidism in mom, heart disease, preeclampsia, eclampsia, fetal dysmaturity, or RH alloimmunization, which is your RH negative mom's had some bleeding. So now we just need to follow up and see how baby's doing. Okay. The other one with preeclampsia, eclampsia, if mom also has like pregnancy-induced hypertension. Can someone tell me how we know the difference between pregnancy-induced hypertension and chronic hypertension?
If they had it before pregnancy and after.
Right. Chronic, you're going to see early on in pregnancy before that 20-week window. Okay, it's going to be that first visit, next visit. Pregnancy-induced are going to have normal blood pressures up until about 20 weeks, and then you're going to see them start creeping up and staying up. Okay, because preeclampsia, majority of the time, does not present itself to closer to term. I have seen preeclamptic people at 23, 24 weeks, but it's not as common. So an amniotic fluid index. So you have a suspension of decreased uteroplacental perfusion, diminished renal blood flow to baby. So you have decreased fetal urination, which results in oligohydramnios, which means what? Too little fluid. We don't have enough fluid around that baby. Oligo. A lot of people you'll hear say, oh, she's oligo. We don't say the whole word. So the abdomen is divided into 4 quadrants. Okay. And the amniotic fluid measurement is taken in each quadrant. They're going to pick the largest pocket that they can see in each part of the abdomen. And then those results are added together and averaged, so divided by 4. Okay. If it's less than 5, that's when it's a red flag. Means there's not enough fluid around baby. Again, I'll look up the numbers for Polly. I can't remember exactly.
So they pick the largest pocket.
The largest pocket in that quadrant, because you want to give the best average. Okay. So they're going to look around for a little bit till they see the best pocket, and then they're going to measure it. Oligo may be the result of fetal hypoxemia causing decreased urinary output. So again, oligo is a bad sign. There's several things that can be going on if you have a mom who's oligo. It also could indicate maybe a small leak in that uterine or in that actual sac. And so mom's been leaking amniotic fluid for a while, which if she has an open area in the amniotic sac, what is she at risk for? I heard it. Infection. Okay, puts her at greater risk for infection for mom and babe. So if the AFI is less than 5, we need to figure out what's going on. do some further assessments. If she's only there for an amniotic fluid index and it's less than 5, they're probably going to go ahead and finish up with the BPP. They're going to continue and do the rest of those other things on that BPP itself. So we talked about the non-stress test. So we're going to talk about the contraction stress test. So non-stress means we're not stressing baby out at all. So mom's just going in, being put on the monitor. We're going to see how baby reacts just to normal everyday life in the uterus. Okay. Contraction stress test is where we're actually going to cause her to contract. Okay. And we're going to see how baby tolerates that contraction process, because if we have issues with baby not tolerating a small amount of like Pitocin, then baby's not going to tolerate labor at all. Okay, and we need to probably do a C-section. So it evaluates the respiratory function, so the oxygen and CO2 exchange of the placenta. It helps identify a fetus at risk for intrauterine asphyxia through observation of the fetus heart rate through the stress of uterine contractions. So during a contraction, that intrauterine pressure increases, causing the blood flow to the placenta to be reduced temporarily, which decreases oxygen to the baby. So a healthy baby is going to be fine. It's going to tolerate it. Its heart rate's going to stay the same. It's not going to have any issues. If it's insufficient, that placenta, then fetal hypoxia occurs, as well as depression of the myocardium, and you're going to see that heart rate decrease. You're going to see a decel. You do need consent for this because it is a procedure. You're giving her a medication. Okay. Most of the time when a patient goes in the hospital, all those papers they sign when they're admitted, that's going to cover this. It's not going to be a separate consent like a surgery. Okay. So her consent when she comes in and is admitted usually will cover this part of it. So procedure for contraction stress tests. Okay. So you need to have the presence of 3 uterine contractions, at least 40 to 60 seconds long in a 10-minute period. It's not typically performed before 28 weeks. It's usually between 32 and 34. Okay. Contractions may be spontaneous or induced with oxytocin or nipple stimulation, which will then cause natural oxytocin release. How do we interpret the contraction stress test? We want it to be negative. Negative is good. Negative decels, negative bad results. Okay, negative is good. This means that baby can tolerate labor more than likely. We don't have any late or variable decels. We have presence of good quality contractions. So that baby is tolerating everything well and can have a normal labor process. Positive is bad. That means if it's positive on that contraction stress test, you have late decels with more than 50% of your contractions. This indicates you have fetal hypoxia occurring. Baby is not going to tolerate the labor process. It's most likely to get worse with stronger and more contractions. Equivocal or suspicious. So this is an intermittent late decels or hyperstimulation of contractions. So where you have contractions every 2 minutes lasting greater than 90 seconds. So you've got too many contractions in that 10-minute period. So baby may be too stressed. So it's not going to be a good indication, because if you have too many contractions, you're overstressing baby. That's not going to give you a good idea of how they're going to tolerate a normal labor pattern, which is 3 to 4 contractions every 10 minutes. Okay. So that's when you're going to have to probably give mom some hydration, slow down that contraction process, and then see how baby tolerates it. We're going to have to do some further testing. So a positive contraction stress test. So that means we've had decels with a non-reactive NST. So baby's not reacting well. We're not having our A cells. Is evidence that the fetus would probably not withstand stress of labor, and we're going to have to probably do a C-section. Okay. So why would we do a contraction stress test? For any pregnancy that's at risk for placental insufficiency or fetal compromise, either due to intrauterine growth restriction, diabetes, post-dates, we have a non-reactive NST non-stress test, abnormal or suspicious biophysical profile. So contraindications of why we wouldn't do a contraction stress test would be placenta previa. Okay, let's discuss placenta previa versus placental abruption, because I think some of you got a little confused in your brain. Because if you have placenta previa, that means what? The placenta is over that cervical os, okay? So what color of bleeding am I gonna see? Bright red. Am I gonna have any pain? No. Okay. Painless, bright red bleeding. My abdomen's gonna be soft and non-tender, okay? Because it's just coming from that placenta itself. It's not coming due to, and you may be having some contractions, but it's just due to that placenta, that cervix opening and that placenta bleeding, okay? So placental abruption, okay, think about this, abrupt, I mean, you got a volcano erupting, so that's how I think of it, abrupting, okay? So then you're gonna have pain, possibly bright red bleeding or dark bleeding, because maybe you had bleeding behind that placenta and now it's coming out. You're gonna have a rigid, hard abdomen, lots and lots of tenderness and pain, okay? So previa, painless, non-tender abdomen, bright red bleeding. Abruption, our uterus is erupting, okay? Sorry, I'm a word person, okay? Helps me remember, so I want to help you remember. So an abruption is where that placenta is pulling away. You could have bright red bleeding, but a lot of times it's darker bleeding. Painful, rigid abdomen, tender to the touch, okay? What causes a placenta previa? Could be multiple births. It's improper implantation. There's lots of reasons that previa can occur. Mom did not make it happen. Nothing made it happen other than just maybe multiple births, history of scarring in the uterine vault, you know, multiple abortions, SABs. But abruption is usually caused by a complication. It can be related to maybe a physical impact, like a car wreck, falling down the stairs, falling, okay? That's going to cause an abruption. There's a reason that it happened. Hypertension, preeclampsia, okay? That's going to cause that abruption. Okay, does that make it clear to everybody? So if they have third trimester bleeding, previous C-section, transverse C-section. Again, remember I drew that uterus on the board a couple weeks ago and we talked about how most of the time we have that little smiley face incision and they can labor after that if they do a trial of labor, okay, a tolic. But if they have that incision that goes up and down in that uterine cavity, they cannot labor, they cannot contract, okay, because the risk of uterine abruption is great, okay. Possible preterm labor, if we already think they have some preterm labor possibly going on, we're not going to give them something to then contract more because we don't want the baby to come now, okay. So, or if they have premature rupture of membranes, incompetent cervix, or more than one baby in there, we are not going to do a contraction stress test. So an oxytocin challenge test or a contraction stress test, okay? This is when you're using pitocin or oxytocin to stimulate contractions. So a positive contraction stress test is where you have persistent late D cells with 50% or more of the contractions. Is this what we want to see? No, we don't want to see this. Okay, we don't want to see any D cells. Earlies are going to be a little bit okay, especially if baby's head's pretty far down there, because what does early mean? Head compression just means that head's being pushed on. What does late mean?
Placental insufficiency.
Placental insufficiency, variable. Cord compression of some sort, okay? Baby's laying on it, squeezing it between the head and the uterine wall, whatever, okay? So placental grading is not done as much these days as it used to be. We used to grade placentas a lot when we did the BPP. They would actually look at it and grade it from 1 to 3. It's not done as often anymore because, again, with your limitations of an ultrasound, mother's body mass, things like that, but it can be a good indicator. So 3 is the most mature and has some calcifications. This is less likely to function, okay? So it's an older placenta. If you have a grade 3 placenta, it's an older placenta, okay? You've got some hardening in there, some calcifications. The blood flow is not going to be as good. That baby probably needs to be born. Of course, 0 to 2, 0 is like immature. 1 and 2 is it's still good. It's within that normal range. But if you get to 3, then that's an older placenta. So factors that age the placenta may be a little faster than just the normal process of it aging. Smoking, post-term, preeclampsia, and gestational diabetes. So tell me, what does smoking, preeclampsia, gestational diabetes have in common that would cause that placenta to age faster?
Vessel damage.
Vessel damage, right. All 3 of those cause vessel damage, which causes vasoconstriction. If you don't have good blood flow, that placenta is not going to function well and it's going to grow old faster. Okay, and kind of the same thing with post-term. As it gets older, those vessels are going to not work and function as well. So the MSAFP, you've heard me say that several times today. So the maternal serum alpha fetoprotein. This is a measurement of protein produced by the yolk sac at 6 weeks and the fetal liver as the pregnancy progresses. It's the main protein in the fetal plasma. It diffuses from the fetal plasma to the fetal urine and is excreted into the amniotic fluid. It can be measured in the maternal serum or in the amniotic fluid. So this is one of the reasons you could do an early amniocentesis. You wouldn't do it till after 12 weeks, once that uterus is up into the abdominal cavity. But we also have to do good education with an early amnio, explaining to mom and dad that it's very risky, higher risk of miscarriage. But it can be measured in mom's plasma serum. So an elevated AFP may mean an open neural tube defect. The AFP leaks out of the fetal circulation into the amniotic fluid and then into the placenta into mom's circulation. It's most accurate between 15 to 16 weeks. So if you have someone that has they'll have a quad screen and an MFASP at the same time. So the quad screen is looking for 4 different trisomies. And then the MFASP is looking for, or MSAFP, I always get my F and S mixed up, is looking for that neural tube defect. So if you have somebody that has that early testing, like the Harmony test, they're going to have this test done at 15 to 16 weeks because it's not going to show a neural tube defect. Okay.
So what happens when the protein leaks?
So that's normal. It's going to leak. And so there's no problem with that. It's just if it gets, you're going to have it in mom's bloodstream. So then you can test for that neural tube defect. So it's supposed to. It's the natural process of what the body does. Okay.
So the maternal serum is different from the alpha fetoprotein?
So they are tested together, usually at the same time, but the maternal alpha fetoprotein is looking specifically for that neural tube defect. Specifically. And then the quad screen, which is part of the other fetoprotein, is looking for those trisomies. And so you definitely need to have the quad screen with the alpha fetoprotein done. And there's several, there's tons of names for them. It all depends on what the lab calls it. So but you're looking for those trisomies. And most of the time, you're not just going to do your neural tube defect screening. You're going to do both of them together. And just unless the patient just says, no, I don't want it done, they can refuse it. It's not a required medical test. Okay. So amniocentesis, this is a diagnostic procedure. It's 99% accurate. We are looking for genetic anomalies with an amniocentesis. Important point to know. With an amnio, we're looking specifically for genetic anomalies, okay? So a sterile needle is inserted using ultrasound guidance into the uterine cavity through the abdomen, removing small amounts, about 15 to 20 mLs of amniotic fluid. I've seen this done many times when I worked in Tulsa. We did them all the time in our office setting. You use betadine to clean the belly. It's a sterile procedure. The physician has sterile gloves on. The ultrasound tech has sterile gloves on, and the ultrasound itself is put into a sterile glove to then scan the belly because we got to keep it sterile because we don't want to introduce bacteria to that baby. The ultrasound person looks for the pocket of fluid, and then you actually can see the needle goes down through the abdominal tissue into that pocket. It's the coolest thing in the world. And then they aspirate, pull it up, and then you send that off for genetic screening. It can be done between 15 and 20 weeks. Most of the time it's done later in pregnancy. You would do it at 15 to 20 weeks if you had a positive quad screen, but it was kind of indifferent on what the actual problem was, because probably what it was, they found a genetic issue, but it wasn't one of those 4 trisomies. So then you're going to then do an actual genetic screening of the baby's DNA, okay? There are some newer lab tests that actually can pull some fetal DNA from maternal serum, okay? But the most accurate way to gather that maternal or that fetal DNA is an amniocentesis, okay? It can detect neural tube defects, blood typing, and can validate anomalies or abnormalities detected by the ultrasound. At 30 to 37 weeks, we're looking for lung maturity, the LS ratio. Okay. If you look in your book on 261, it goes through the procedure. So you are going to do an informed consent. So it's going to be like a surgical consent. Okay. Because it's a big procedure. It's an in-office invasive procedure. You're going to get vital signs before and after, including you're going to measure the fetal heart rate before and after. After the procedure, you're going to instruct the woman to contact if you have any unusual fetal movement or no fetal movement, vaginal discharge that's clear or bloody, uterine contractions or abdominal pain, fever or chills, and you're going to encourage them to just have light activities for 24 hours and increase their fluid intake. If the mom is Rh negative, we are going to give Rogam when we do the amnio. Anytime you put the mom at risk of being exposed to that fetal positive blood type, we're going to give Rogam to cloak that positive blood type in mom's bloodstream. We're going to document the maternal and fetal response to the procedure, vital signs or any kind of discomfort. We're going to measure the fetal heart rate, look for presence of contractions. So we're probably going to do like an NST. We're going to put her back on the monitor for a little while to monitor baby and contractions. We're going to assess for any kind of bleeding or fluid leakage from the site or vaginally, or look for any abnormal symptoms. And we're usually going to have them lay on the bed for about 20 to 30 minutes before we get them up, because we want to allow that to kind of naturally seal over by itself. We give local. You give lidocaine locally into that tissue. They use a spinal needle. So if you've ever seen a spinal done through your clinical, it's a very thin, small needle. Okay. So most of your nerve endings for pain and discomfort are going to be in those top layers of tissue. And so that's what we numb for. So why would we do an amniocentesis? If you have a woman who's advanced maternal age, 35 years or older, on her due date. If you have a baby at risk for chromosomal problems, you have a positive serum quad screen. Sometimes can be false positive, so we want to double check by actually looking at the fetal DNA. An AFP, HCG, or unconjugated estriol, or a D-dimer, a dimeric inhibin A, okay? So main thing I want you to remember for an amnio is if you have a positive MS-AFP or quad screen, that's what we're going to then look for, those anomalies. Or there are anomalies or abnormalities noted with the ultrasound. Sometimes if a family already has a history of a baby with a birth defect, that's indicative of doing an amnio, so that person can make an informed decision whether or not they want to carry to term. Okay. So risk and side effects: vaginal spotting, cramping, amniotic fluid leakage, chorioamnitis, where they get an infection in that chorion and the amnion, fetal loss. Okay. We want to assess for non-reassuring fetal status during the procedure. So of course, while they're doing the procedure, we can't necessarily assess heart rate, but we're going to assess heart rate of baby before and after and do that NST before and after. Okay. If they're 15 to 20 weeks, we're not going to be able to actually put them on the monitor to monitor for contractions because you're not going to keep baby on there. Okay. You possibly could see a contraction pattern if they were contracting, but you're not going to keep the baby's heart rate on there because it's too small. So you would just use a Doppler.
So we're using the Doppler to assess the heart rate.
If it's less than, if it's 15 to 20 weeks, you're just going to use your little pocket Doppler. So evaluating fetal lung maturity. So in amniocentesis, they're going to do an LS ratio. Okay. Lecithin and sphingomyelin is the two components of surfactant. Okay. If one of those components are there, that it indicates a risk that the risk for respiratory distress level is low. So that baby, if there's one of those two on the test, that means baby has surfactant and their risk for respiratory distress is low. So they could be induced or delivered earlier. So when I worked in Dallas, they would do this LS ratio, and apparently it's an actual like little vial that they would put the fluid in and shake it. And they'd come down and say, "Oh, she's shake positive. We're going to do her C-section today." I'd be, "Oh, like, thank you." I already have 5 lined up. Because they literally had C-section clinic 1 day a week with high-risk C-section clinic for all these people who are going to be repeats. And of course, it was a teaching facility. And so they would say, "Hey, if we can do this test with amnio today, and if the baby's lungs are mature, you could have your baby today." What woman's not going to say yes? Right? Like, sure, I want my baby today. So then they would do these amnios, and it's basically so the residents could be educated on how to do these procedures, And they would do this LS ratio, and they'd come down and be like, "Oh, they're shake positive." And so we would have 5 or 6, 7, 8 lined up in chairs to go back for C-sections that night. So we would be doing C-sections all night long. It was like, you get a baby. Yeah, you get a baby. You get a baby. And so, not to brag or anything, but I was one of the fastest ones for admitting and getting them ready for C-section. So they would pull me to west side, and I would walk in and see 5 or 6 of them lined up. And I knew what I was going to be doing for the next 2 hours. Would be admitting, starting the IV, putting the Foley in, which we put the Foley in the room, not the OR. That's just how they did it. And get them prepped, floor prepped, all that lovely stuff to go back for their C-section. And we would have a big whiteboard with 20-something patients written on it, and you would have number 1, 2, 3. They literally would number them out. Yes, ma'am.
This is done for advanced maternal age, and if something's wrong, then they're gonna get this done.
Mhm.
And then if it's mature, like the Ellis ratios are mature, why do they take them out? Like if the baby, like even if the baby doesn't need to come out, they'll still take them out? Like they'll give them that option? Like if you have them lined up. like-
In the normal setting, no. But in a residency program, yes. So, and it was because the volume of patients we had. We did 50 to 60 deliveries a day. 16,000 deliveries a year. Okay, so when you have that volume, then you just, you know, you have to have babies faster than slower. And so it was a teaching facility, so they would do lots of procedures that maybe weren't necessary for a patient, but they had to learn.
Like if they have insurance, or Medicaid or something.
95% of these people were Medicaid.
Doesn't have to be over 37 weeks?
Not necessarily if you have an indication. If you have an indication, they have one high blood pressure, they can induce you. Pretty much, that's all it takes. Okay. So remember your LS ratio, if it's 2 to 1, you have at least one of those 2 factor proteins, you can have a baby. That means that surfactant is there, baby can be delivered, okay? Probably an important thing to know.
So you have to have both of them.
Nope.
No?
One of the 2.
No, like you have to have both of them to be okay. Like you don't need it.
Both of what?
The surfactant.
So the lysithrin or the sphingomyelin, one of those 2, if you have one of those 2 show up in your amniotic fluid, then baby surfactant is present and you can have the baby. So you don't have to have both show up. You just have one of the 2. So your ratio will be 2 to 1. If it's 2 to 2, you're even better, but 2 to 1 means you can have the baby. Lungs are mature or surfactants there.
Oh, okay. I get it. I
Yeah.
have to say that.
If you have neither, then the baby's not ready to go.
If you have, yeah, if it's 2 to 0, you don't have surfactant that's there, so you have to wait. Lungs are not producing surfactant, so can't have a baby yet.
How often did you see that? That the baby wasn't mature?
Sometimes, yes, they would do it in not mature, but if baby is in distress or mom is severely preeclamptic, almost to eclampsia, then we have to have a baby. I mean, there's indications where sometimes baby has to come out even if it's not time.
So it could be 2 to 3.
No, there's only 2. There's only 2 proteins. Those 2 proteins, lysithrin and sphingomyelin,
It'd be 2 to 2 then.
2 to 2 or 2 to 1. If you have 2 to 1 or 2 to 2, you're good. Means the first surfactant's there, it's present, and you can have the baby.
And 2 to 0 is that.
2 to 0, there's no surfactant present, and the lungs aren't mature enough to deliver.
Would you give more betamethasone then?
Well, if they haven't done betamethasone, you wouldn't give more. You're only going to give the 2 doses. But if you are testing at an appropriate time after the 2 doses, they should be present. So like if you give the second dose, we can't have a baby an hour later. You've got to have time for that second dose to go through the mom's system into baby system and then trigger that surfactant release. Okay. Phosphatide, whatever, the PG, because I can't say long words like that. I can't say supercalifragilisticexpialidocious. Appears when the fetal lung maturity is attained, okay? If present, then your respiratory distress syndrome risk is low, okay? Most physicians use the LS ratio. The other one you could use is the lamellar body count. Again, almost all the time we use the LS ratio. That's your most common one that you're going to see. And in your book on page 263, there's a table that kind of compares all of them. So chorionic villi sampling. So it's done in the first trimester at 10 to 12 weeks. It detects fetal chromosome, enzyme, and DNA content. It cannot detect neural tube defects. Okay, so the chorionic villi sampling cannot detect that neural tube, so you have to still have that MSAFP. It's performed transabdominal or cervical. It's obtained from the edge of the developing placenta. So they actually put a needle through and gather cells from that developing placenta, not the fluid itself around baby, it's from the placenta. So the risk for going along with this, you have failure to obtain the tissue, you're at risk for spontaneous abortion, you could cause fetal limb defects by actually where the limb is pierced by the needle. Again, if mom's Rh negative, you're going to give RhoGAM. You're at risk of causing rupture membranes, bleeding, intrauterine infection, and then I have the fetal limb defect on there again.
It's supposed to go into the placenta, but can go into the.
So it's supposed to just go to the placenta, but if a physician's a little gung-ho and pushes a little too far, it could go into the fetal limb and cause defects. Okay,
So which one would have like more risk, the abdominal or the cervical?
well, it's just gonna depend on baby's life. They're gonna have to look and see where the placenta is, and it's just gonna depend on where baby is and how they're positioned. Yes, ma'am.
So is this the one where they do like a DNA test before like a paternal test?
You can do that with the amniocentesis. You don't have to do it with this one. But most physicians will not do it during pregnancy. They'll just wait for baby to be born. They're not going to make a woman go through a procedure like this or the amnio to do DNA testing. He's just going to have to wait. And I have had calls.
And to figure out where the placenta is it ultrasound?
Yep, it's ultrasound guided, just like your amniocentesis. They're going to look with the ultrasound, see where the placenta is. It's guided just like the amnio, where they follow the needle to the edge of the placenta to try to collect cells. Some other tests that may be performed: percutaneous umbilical cord sampling or cordocentesis. This is to obtain a pure fetal blood from baby in utero. It's used to diagnose hemophilia, hemoglobinopathy, and infection. Fetal fibronectin test is done. It's a glycoprotein produced by the trypoblast and other fetal tissue. It's used to predict preterm labor or PROM. Okay. So the fetal fibronectin is actually a vaginal swab that you do and send out. The only time you really ever do that is if you have a person who comes in recurrently complaining of contractions and preterm labor. It's not done as often as other tests done, but we do them sometimes. If it's positive, if that glycoprotein is there, she's at greater risk of going into preterm labor. Any questions? Yes, ma'am.
So back to the RH, the shot that you give them. So is it each pregnancy or with just one time that you give it to them?
No. So let's break it down. Okay. I feel like I need to start wrapping.
So you want to, you feel like you need to start wrapping?
I said, let's break it down. And I said, now I feel like I need to start wrapping. Y'all would be covering your ears because I'm not good at it.
All about that.
I mean, wrap the next lecture. Okay, so if we have an Rh negative mom, okay, this is mom. If she's pregnant with an Rh negative baby, are we gonna have complications?
No.
No, only if she's pregnant with an Rh positive baby. Because if she gets exposed to that fetal blood, her body's gonna be like, oh my gosh, this is not right. I've got something weird in here, and it's gonna start attacking the baby, okay? So in the first pregnancy, are we gonna have complications?
No.
No, okay? We're not gonna have complications because even though her body's building up antibodies, it's not gonna have enough time to build up enough to cause any issues with that baby.
But you still treat it.
you still treat it. So we are going to give, if mom is RH negative, baby's RH positive, and we don't know yet, right? So we're still going to treat mom because even if baby's negative, giving her Rogaine or the immunoglobulin is not going to do anything to her. It's not going to cause a problem. Okay. So the first dose, when's it given? 26 to 27 weeks. Okay. Or if bleeding occurs. So say she has bleeding at 8 to 9 weeks in pregnancy, we're going to give Rogaine. If she has an amniocentesis that can cause bleeding, we're going to give Rogaine. Anytime she has a procedure that could cause that fetal blood to be introduced into mom's bloodstream, we're going to give Rogaine. Okay. Second dose, when's it given? Postpartum. Okay, so after delivery. So at postpartum, some facilities do check baby's blood type. If baby's negative, we don't have to give it. Because we know even if mom is exposed to baby's blood type, it's a negative blood type and it's not going to form antibodies. Okay, it's not going to trigger the body to say that's abnormal. I got to make a defense mechanism against it. So some hospitals don't test, and so we just give all moms Rogaine. But we do what's called a fetal bleed screen. That actually looks at mom's blood to see is there what ratio of fetal blood is in her blood. Okay. And we may have to give up to 3 Rogaine injections, depending on the amount of fetal blood she's been exposed to. Okay. Not all facilities do that either. Just depends on the provider. But if you do a fetal bleed screen and you do, indicates that you need to give 3 shots of Rogaine, that actually decreases her risk of building those antibodies. And that's why a lot of physicians do the fetal bleed screen. Is she going to have it with her second pregnancy? Yes. Okay. Because do our antibodies last forever? No, not always. Okay. That's why we get booster vaccines. Okay. So because we know our antibodies don't last forever, with the next pregnancy, we're going to have to give her another Rogaine at 26 to 27 weeks. And again at postpartum. The only time I have ever not given a mom Rogaine, well, I have 2. One, she was Jehovah's Witness, and because it is somewhat of a derivative of blood product, she refused Rogaine. But she also was like a Gravida 15 para 4.
Oh my gosh.
But it was because of the multiple miscarriages, because her body fought against those pregnancies. The second one was where it was a husband and wife who were married. She was negative blood type and her husband was negative blood type, and we had proof of his blood type on record. We just have to trust that no one stepped out. Okay? That no one stepped out. The wife didn't step out. Okay? Gotta just have that trust in them, because that's when education comes in as important with that person. And I was honest with her. I'm like, just so you know, if there's any possibility that it could be anybody's beside your spouse, we need to know, because if you're negative and that person's positive, you are running a risk of causing complications in later pregnancies. But they were good with it, and we didn't get Rogaine. So yes, we're going to give Rogaine with every pregnancy at 26 to 27 weeks postpartum, or anytime there's bleeding or a procedure done that indicates that mom could be exposed to fetal blood.
So even if it's like 10 weeks pregnant,
Yes. So if a woman is RH negative and has a miscarriage, does she need Rogaine? Yes. She needs Rogaine, because there's still a chance that she could have been exposed to fetal bleeding and her body's going to build those antibodies.
so then why wait 26 to 27 if you can give it anytime?
Because we need it to start cloaking later, because we want to make sure we continuously have that cloaking effect going on. But then if she did have complications early on, we would give it, because we want to then. But also you have to be careful, because when you do mom's antibody screen, if you give the Rogaine too late in the pregnancy, it's going to show a positive antibody screen. And it's just showing that ROGAM. And so they'll call and say, hey, I see she's RH negative. When did she get a ROGAM? We're like, oh, well, she missed her appointment. She didn't get it till 32, 33 weeks. Okay, well, that's probably why she has a positive antibody screen.
And so it's just given to all negative moms?
Yep, if you are a negative blood type and you're pregnant, you're gonna get ROGAM.
So you get it, and then how long after can you get those procedures done? Like if you get the shot, and then how long do you have to wait to get the amnio done?
You're usually gonna have the amnio done and then the ROGAM done the same day. Yeah, there's no waiting period. Usually that's gonna be if I had an RH negative mom getting a procedure like that done, it was given in the same visit. There's no waiting period. Because the sooner we can get it on board, it decreases that risk of the body building antibodies.
Like you just said, the body like start fading, so.
But then, so if she was to have an amnio at 10 to 15 weeks or 15 weeks, she's gonna get another ROGAM at 26, 27 weeks. And then she's gonna get a ROGAM postpartum.
But that day that the procedure's done, it's not going to already expel like anything?
It probably will a little bit, but you're still gonna go ahead and you're gonna give it that same day. You're not gonna give it before, you're just gonna give it the same day. Okay, fetal monitoring. So we've kind of touched on this several times throughout lecture, okay? And like I said, I'm not going to expect you to be proficient, a pro, right? You're not gonna be a pro at this, okay? We just need you to see that's good, that's bad, how am I gonna fix it if it's bad? Okay, that's what I need you to tell. So when you're placing fetal monitors, we're gonna do the Leopold. We're gonna put the ultrasound over the baby's back. If possible, sometimes you do have to switch the other side. And it interprets the signal and records it on the graph paper. Okay, you have a Doppler, which is an ultrasound transducer that's on the outside. Okay, so when I say Doppler, it does mean both. So you've got your little Doppler that's got the little wand on it. You listen when they're early. This is still a Doppler. It's just a bigger conductor and transducer that picks up sound better. Okay, and it plugs into the machine. Disadvantages with external monitoring: susceptible to interference, may have a sketchy tracing. If you have a mom that has a lot of extra adipose tissue, sometimes it takes a lot of finagling and moving and getting her in the right position. And sometimes you feel like you're cutting her in half with the straps to be able to get it, but you have to. You've got to monitor baby, especially if baby's in any kind of distress or if she's on Pitocin. So sometimes you're chasing baby, it's hard. Okay, you're in that room all the time, hands on belly, trying to keep baby on the monitor. Advantages: it's non-invasive. Okay, doesn't cause any complications with like choreo or any other issues. It just goes on mom's belly. Okay. You don't have to have your membranes ruptured to do the external monitors. Okay, can be placed at any time. So, okay, let's go back to this. So some facilities, so we do not have to continuously monitor everyone. Okay. Southwest Med has, yes, sir.
Back to the interference, if they're like hyper reactive bowel sounds, will that interfere too? Or
No, not the bowel sounds.
Just if they're,
Because you have to remember, when you have a baby here, your bowels are here and here. They're not here anymore. It's just baby. Okay. So with external monitoring, we do not have to do continuous monitoring. Okay. If you have a woman who's in active labor, has no complications, has no decels, you can do what's called intermittent monitoring, which is every 30 minutes where you go in and listen through a contraction. Baby's reactive, has no decels, take her off the monitor. Southwest Med has a policy for intermittent monitoring. We are just used to slapping monitors on everybody because that's what we think we're supposed to do. Okay, new nurses who come in who are trained, what do? You see everybody go and stick them on a monitor, right? Okay, but there are policies. If you have a patient who wants to be up and moving and there's no indication that we have to continuously monitor, be proactive. Call your physician and say, hey, she wants to be up moving. Can we do intermittent monitoring? And if she's good, most of the time they're gonna say yeah. And then you just have to monitor through a contraction every 30 minutes.
So it's not a standing order, like they can't, you have to call the doctor to.
There is a standing order, but you have to know your physician and go ahead and ask. It's gonna be better. Okay? There is a standing order for it, but it's just not, we don't use it as often. Physicians, I think, sometimes feel out of control when they can't see what's going on with baby, which is understandable. If you can't see what's going on with baby, how do you know if baby's well? You know? So you're looking at continuous monitoring being with more high-risk things. So tell me some high-risk things that you think we would have continuous monitoring with. Preeclampsia. History of miscarriage, okay. More so if they have late term. So you're looking at like stillbirth. Right, if they have low fluid, high fluid, they're preterm, diabetic. Are we gonna give them Pitocin without continuously monitoring them? No. You're gonna rupture that uterus, Manny. Are we gonna give magnesium to a hypertensive patient without monitoring that baby? No. Okay, so there are lots of indications of why we do continuous monitoring, okay? Different facilities have different protocols. Some people, if they get cervidil, they're monitored continuously until it comes out because it is a hormone that can cause contracting. Here we don't. We just monitor her for the first couple hours. As long as we have a reactive strip, then we can take her off so she can rest. So when we have these external monitors, how often are we going to be assessing? Okay. So if we do have someone on continuous and they're a low risk pregnancy, we only have to document on that strip every 30 minutes. We don't have to document every 15. Okay. Some nurses will just do every 15 anyways, because that's what we do. We're used to it. We're documenting every 15 minutes. Okay. So usually in the early stage, you can do Q30 after they're in active labor, past that 4 to 6 centimeters, you're going to do every 15 minutes. You're going to assess the fetal heart rate before you do an AROM, which is artificial rupture of membranes. Before ambulation, before you give pain medications. But of course, if they're on continuous, you're just going to look at your strip for that last 10 minutes. You're going to assess fetal heart rate after the rupture of membranes, being spontaneous or artificial. She says, my water broke. You're going to look and see how's baby reacting. Once you start Pitocin medications, when you're doing a vaginal exam, and after they've ambulated, you're going to monitor them again. So there's internal monitors, and we've talked about these a little bit. I've showed you some in the skills lab, and I will show you guys again today. Today, tomorrow, and next week, the 3 groups that have their simulations. So when is it useful? It's useful when you can't monitor externally, can't keep baby on monitor. Okay. So we're going to do what's called a fetal scalp electrode. It's this little bitty coiled wire that you actually take and screw into the top of the baby's head, into the soft tissue, and it picks up the baby's heart rate. Okay. So when are we going to use this? You can do it once the cervix is dilated to 2 centimeters. Okay. It can be 2 centimeters. It's a very thin little tube that you use to insert it in. So as long as you can just fit the tube through the cervical os, then you can do it. The water has to be broken. Okay. You can't do this until the water's broken. And you have to be able to determine fetal position. We don't want to screw that into a little baby's bottom or leg or shoulder or forehead. Okay, only in the top of the head. So if you can't determine the lie of baby, then have someone else help you assess. Maybe we need to have the doctor come in and do an ultrasound so we can see. Yes, you want it in that in the top. I mean, it doesn't have to be over the fontanelle. It can be over the bone itself, but you want it here. You don't want it anywhere else on the body. I mean, it would transduce, but that's not the ideal location to have it. This is going to heal faster. You don't want a scar. Okay.
So there's no complications.
I've had babies that when they're born, it gets pulled, and so you actually have a small laceration. So I've seen where they've had sores where they were, but most of the time, if you are careful to not pull or tug, like during exams or rolling, then you're less likely to cause injury because it's a very small, like that's the smallest needle that we use on the baby to do like their Hep B and their vitamin K is that little teeny tiny one, but it's kind of coiled.
Would you get program or Rogan if?
No, because you're going to get it postpartum anyways. So, but can someone tell me some reasons we wouldn't do an FSC on a woman? Mom is Hep B positive. We're not going to do an FSC on baby. Okay. HIV. Okay. Anything else? Huh? Yeah, if they have an active STI, you're not going to do a fetal scalp electrode. If they're group B strep positive, okay, if they're GBS positive, we can do them, but we prefer not to do them because then you're going to then expose baby sooner than later to that GBS. Okay.
So if mom didn't get the Rogan and if she needed it, then you would not do this, right? Like if she was like a Jehovah Witness.
No, you could still do it. I mean, because she's going to be exposed.
Anyway.
Yeah. Because you have to look at risk to benefit. Is it more beneficial to know what baby's doing and take that slight risk mom's been exposed when she's probably already been exposed?
And what's the contraction one called again? Where you like insert it into the fluid?
We're about to talk about that. Get ahead of me there, man.
Do they always do this?
No. Fetal scalp electrodes are not done often. It just depends on the facility. Some facilities use them all the time. And it doesn't have, the fetal scalp electrode can actually be placed by a nurse as long as the nurse has been checked off on that skill. Okay. We have a few nurses here who have been checked off. I've never been checked off because we always had midwives or the physician there to do it. And when I worked in Arkansas, the nurses there did it. But it wasn't anything I ever had to do. And so it's not hard. You know, you just have to know how to use the device itself and make sure you're accurately placing it. But nurses can place the fetal scalp electrode. They cannot place the IUPC, which is what we're about to talk about. The intrauterine. Oh, look, there we go. I have a picture. So you can see it just goes on to baby's head. There's a little kind of coiled wire that comes out and plugs into a transducer that then is stickered to mom's leg and then plugged in with the cord from the monitor. So an IUPC is an intrauterine pressure catheter. This is used to monitor contractions. So remember, our topometer transducer that's on the outside of our abdomen cannot tell us how strong our contractions are, right? They can only tell us how often and how long they're lasting. Can't tell us our strength. The only way we can tell is by patient, okay. This would be important to know. Just saying. So if I go in and I have a question about, you go in and you feel you palpate the belly and it feels like your forehead, what's the strength of that contraction? Strong. What's my chin? Moderate. What's my nose?
Mild.
Mild. Okay. So during the test, if I see y'all doing this, I know you're answering correctly. Okay, so an IUPC or an intrauterine pressure catheter is an actual tube that goes into the uterine cavity around the baby. Okay. It actually, the ones we used to use years ago were pressured with water. The ones we use here at Southwest Med and most places you are pressurized with air. Okay. So it's an internal monitor that actually measures the strength of the contractions. It's the same requirements as the fetal scalp electrode. Their water has to be broke. They have to be at least 2 centimeters dilated to be able to do it. Of course, no high risk, no HIV, Hep B, all those things. Okay. This is the only way that we can measure the strength of a contraction. Okay. So that intrauterine pressure catheter is inserted, goes in beside baby, around baby, and then measures every time that uterus contracts, it measures the pressure in that space. Okay, using the air that is in it. And then it will accurately measure on my contraction, on my strip, when I see that mountain go up, that is really how strong it is. Okay. So most places do what they measure via what's called Montevideo units, where you actually count out each box in that contraction, and you want a range over a 10-minute period. If you're below that range, they're not strong enough. If you're above that range, they're too strong, and you need to back off your Pitocin a little bit. Here, they don't count the Montevideo units. They actually just count. They do count the boxes per contraction, and you want so many boxes per 10 minutes. Okay. This is something you yourself will never need to know unless you work in OB. Okay. So I'm not going to ask you how do we measure contraction strength with an IUPC. Just know that the IUPC is the only way we can actually measure strength. Okay. The intrauterine pressure catheter is the only way we can measure how strong contractions truly are. So when we're measuring contraction patterns, you guys have practiced those strips, so you know you're going to measure from the beginning of one contraction to the beginning of the next. The duration is how long that contraction is from the start to the finish. And then intensity, again, if it's external, we're only going to be able to do mild, moderate, strong. If we have the internal, then we can measure out the actual amount. So fetal heart rate baseline, your average is 110 to 160. So if I'm a nurse and I go in and the fetal heart rate's 115, the mom says, is that good? Yes. Am I going to need to do any interventions? No, just keep monitoring. Baby looks good. So you're going to look at the average heart rate over 10 minutes. So you guys know, you just take, and if you can draw a line straight through it, even if you have a little bit of variation above and below, you want to get the average, okay, of that heart rate. Tachycardia is anything greater than 160 over 10 minutes. Marked tachycardia if it's greater than 180 over 10 minutes. So what are some causes that could cause some tachycardia? Early fetal hypoxia, maternal dehydration, administration of a beta sympathomimetic drug. I learned my phonics. Amnionitis, which is an infection, maternal hyperthyroidism, or fetal anemia. The cause that you're going to see the most is fetal hypoxia. Okay, baby's not getting enough O2 through that placenta. Bradycardia is anything less than 110 over 10 minutes. Causes, you have stimulation of the vagus nerve, so you have prolonged head compression, application of forceps or the vacuum extractor, or prolonged scalp stimulation. So a lot of times, if you have a baby that's decelling, some nurses will go into a vag exam and kind of stimulate the baby's head to kind of make the heart rate go up, and that works most of the time. But if you stay in there too long, you're going to bring it back down because you're going to vagal them. Their heart rate's going to drop. Okay. So drugs that stimulate the peripheral nervous system or block sympathetic nervous system. So anesthesia or regional blocks. Prolonged cord compression can cause a vasal response. Fetal dysrhythmia. So maybe the baby has a complete heart block. Hypoxemia or late fetal asphyxia. We're going to monitor the maternal pulse and make sure we're not picking up mom instead of baby. We're going to make sure mom isn't cold. Okay, if mom's cold, it can bring down baby's heart rate because baby's temperature is going to decrease. Or we have a possibility of it showing us that we have a placental abruption or uterine rupture. Primary, we need to let the doctor know, and then we're going to reposition. Okay.
For the abruption.
Nope, for the bradycardia. If we have bradycardia over a 10-minute period, we need to go ahead and let doctor know, and then we're going to intervene. If it's a decel that the baby's way down low, then we're going to intervene and call the doctor. Kind of a little backwards, okay? Bradycardia, baby still has a normal heart rate. It's not a decel that we're seeing. We're seeing a change in baseline. It's gone below that normal 110. We need to let the physician know. But Then we're gonna, reposition mom, see if that helps
After you call it.
after you call a doctor on bradycardia. Now, if it's a D cell, like a late D cell, variable D cell, we're doing our big 5 first, then notifying the physician, which is the 5th of your big 5.
So it wouldn't hurt you then if like you intervene first and then let doctor know for bradycardia?
I mean, no, but in NCLEX world, okay, in NCLEX world, you're gonna let the doctor know first, and then you're gonna intervene. Okay. So baseline variability. So we've talked about this. Absent is that flat line, the asystole. Okay, you don't see any variation in that line at all. Minimal is 5 beats or less. That's very small. Okay, a lot of y'all put minimal on your fetal monitor strips worksheets. Those were moderate. It looked minimal because you're like, oh, that's not very much movement. But if you were to actually measure out, it was greater than 5 beats. Okay, 5 beats is only half of that little box or less.
Is it also a collective too?
Yeah, you're looking over the 10 minutes.
So if you only had like 3 minutes of moderate and then
Right.
7 minutes of then you would.
You would say minimal, right? Yes, it's over your 10-minute period. And then moderate is 6 beats to 25 beat variations, and then marked as anything above 25. Reduced variability is the best single predictor for determining fetal compromise. Okay, so if you went from having a baby that had good variability and over time you've gone minimal to no variability, then you know that baby is no bueno. Okay, we need to get that baby out fast. So when you have decreased baseline variability, the fetus is has absent or minimal variability. They're at the highest risk for fetal acidosis and hypoxia. Very bad sign, very ominous if you also have late D cells. So if you have minimal to no variability and late D cells, we're going to the nursery. Baby's gonna have to probably be recessed. Something's wrong. Causes of decreased variability, we have hypoxia or acidosis, drug administration that depresses the CNS system like Demerol or Vistaril. So if you have a mom that had good variability and we've just given a medication that we know can decrease the variability, I'm not going to be too concerned, okay? Because I know once that peak time of the medication has come and gone, I should see a change in baby's variability back to normal, okay? I'm not going to be overly concerned if I know I caused it. So if on the test I say, I just gave Demerol, now I see minimal variability, is that bad? No, I caused it. If it doesn't resolve, okay? If it resolves and you have good variability after your peak time of your medication, you're good, okay? I caused it, not a bad thing. If I didn't cause it, bad thing, okay? So the baby could be sleeping. You're going to see a change in variability, but it should never go to that completely flat line with sleeping. You're going to see maybe from moderate to minimal, but then you're going to see it change once baby wakes up. Fetal anomalies that can affect the heart, the central nervous system. Okay. The fetal dysrhythmias, previous neurological insult, or tachycardia. Marked variability. Now this is going to be like you're past that 25 constantly. You can have early mild hypoxia. The variability increases to try to help compensate. You have fetal stimulation or activity, so acoustic stimulation, abdominal palpation. You just place a fetal scalp electrode. So you're going to see baby come back down to that minimal. Sometimes you're going to see fetal breathing movements. It's going to cause marked, okay, because they're breathing, and so you can actually almost see a pattern, a breath with those heartbeats, okay. If mom is advanced maternal age or if she's on any kind of stimulant, you're going to see marked variability with baby. So here is all together. So your no variability, it's like asystole, okay. There's no change in that line. Okay. Minimal, you're going to have slight changes, but it's not going to go without, it's going to stay within half a box. because one box is 10 beats, so it's gonna be 5 or less. So if it stays within that half a box all the way across, then it's minimal.
So that's the one where you can say that they're sleeping or it's after bedtime.
Right, exactly. You've decreased the variability from this to this, which average to moderate is within the same. Okay, and like Joe said, we're looking at the 10-minute period. Okay, so even though I may have some variations within that 10-minute period that would look marked, it's not a constant marked variability. Okay, I'm averaging it over that 10-minute period. Then your marked variability is where you constantly are staying outside that 25 beats per minute. Okay, and you may still see a little bit of normal moderate in there, but the majority of that 10-minute strip is outside of that 25 beats. Okay, and sometimes it's really hard to tell. That's why on our system here, we have a tool that you can pull up and actually put the little box over it. If it's outside of the 5 beats per minute box, you know it's moderate. If it's outside of the moderate box, which is greater than 25, you know it's marked. Okay, so you can actually measure it. And those are good tools to use while you're still learning. And there's times still that I'll be like, that's so close, I don't know. So I'll pull up the tool and see.
So with minimal, could we say baby is sleeping?
Possibly.
Okay.
But if you see it over a long period of time, more than just like intervals of maybe an hour to an hour and a half, where you've had a good strip and now you've got minimal and now baby's waking up and you see moderate again, then you know baby was probably sleeping. But if that's your constant strip, that's not good. You've got some fetal hypoxia going on. Accelerations. Remember 15 by 15. Okay. Fetal movement is going to cause it. Sometimes you're going to see it with contractions. Just means the baby's doing good. You have A cells, baby's A-okay. Okay, baby's good. And it has to be 15 by 15 from the baseline. Decreased or lack of acceleration could mean extreme maturity. So those early babies, you're not going to see them. Intrauterine growth restrictions, medications such as beta blockers, CNS depressants, or potential hypoxia.
So like the calcium channel's okay, right?
Yes. That's your nifedipine. That's what we're going to get procardia. And that's going to help reduce contractions if we need it. The nifedipine does. But we don't, what do we not give with nifedipine? Okay, can somebody tell me, because you're going to do this in simulation, you're going to need to know this. What is my antagonist to magnesium? Calcium gluconate. Okay, so if I have a mom who has mag toxicity, so her DTRs are gone, she has none. She's very lethargic. She doesn't want to wake up. I'm going to have calcium gluconate at my bedside, and I'm probably going to give her some. Okay, because we want to reverse the effect of the magnesium. So D cells, it's a periodic decrease in the fetal heart rate from the baseline. So we have several types. We have early that go right along with the contraction. Again, we know that's head compression. Late starts at the peak of the contraction and happens after. Okay. This indicates uteroplacental insufficiency. A variable can be V or U-shaped, can be wide sometimes. You're going to see some wide variables. And it happens at varying times. So remember, a variable happens at varying times. It doesn't happen with a contraction always. It can happen before, it can happen after. It's just random. And this just indicates the cord has been compressed in some way. So again, early, you have your peak, you have your nadir, which is the lowest point of your D cell, and it matches up with that contraction, okay? That's an early. A late is where you have the peak of your contraction, the start of your D cell, and it happens after that contraction, okay? So that's a late. So what are our interventions?
To the left.
Okay, we're going to change their position first. Then we're going to start a bolus. Then we're going to give some oxygen. And if she's on Pitocin, we're going to stop that Pitocin. Okay. And then you're gonna call the physician. Now, sometimes these won't always happen in this order. Sometimes if I'm there and I'm bolusing my IV fluids, I'm gonna hit stop Pitocin at the same time because I'm at my IV, okay? But as long as you tell me first that we're moving positions, because that's gonna help change baby's position, it's gonna help take mom off those major vessels. Hopefully it will cause baby's heart rate to come up. Then I'm doing those other things, okay? If I have a co-worker in there with me, I can send them to call the doctor, but do I leave the patient to call the doctor? No, we need to fix this baby, okay? This baby needs help. We're there to help it. That's when you can push the call light. The door's open, help! People will come running if you yell help.
I said, hey, to someone earlier, like last week, and Tammy came running to me. It's like,
What's wrong? I mean, just because we know there are some times you're in certain circumstances to where that's your best way of calling out and having someone come is yelling out the door. Okay. I've even sent spouses, mothers, hey, can you go to the nurse station and tell them I need somebody in here now? Because nobody's answering the call line. Because they're busy. It happens. Oh my gosh, last week. I need to count. Pretty sure we had 20-something deliveries in like 3 days. Yeah. Some of y'all were there in that time. It's bad. I worked Friday and Saturday. I question myself sometimes because then I work this Friday and Saturday. Okay. So on your test, if I give you a fetal monitor strip and that person is having late decels, which means what? Cord compression, but what does it look like? I have my decel with my peak. When is my contraction or I have my contraction with my peak. When is my decel starting? After that peak. Okay, that's a late. After. It's late to the show. Okay, show's happening or it's peak of the show, it's late. It's just not showing up. Okay. What am I gonna do? Big 5. Okay. If I have a mom whose water breaks and baby decels immediately, what am I gonna do? What am I gonna do? Her water just broke and now I have a baby in the 90s.
stick the hand up in there.
I'm gonna check her cervix and I'm gonna see where that cord is, right? Because if that cord is in between that head and the vaginal canal, what's gonna happen?
Cord compression.
Cord compression. So then what am I gonna do?
Leave your hand in there.
I'm gonna leave my hand in there. I'm not gonna move it and I'm gonna yell help. Right, okay? Do not take your hand out. Now, there are a few instances, some NCLEX questions you may see, and I will just make you aware of these because NCLEX world is perfect and doesn't always work the way we do on the outside. Trendelenburg can be used. Knee chest position can be used. Okay. Again, gravity, you're pulling baby's head away from that opening. But most of the time, if you have a woman's water break, baby all of a sudden decels, you're going to do an exam. Do you feel a cord, pulsating cord? I'm going to push it back up there, right?
No.
No.
Good.
I'm not going to push that cord back into that vaginal or into that uterine vault. Why? Wrap around baby's head. I could puncture the cord, cause bleeding, right? I'm just going to push baby head or whatever the presenting part is up and away so I can reduce the pressure on that cord. Okay. Okay. So variable decel, you're going to see it varying. You're going to have that V or U shape. Sometime you'll have what's called a shoulder. So you'll see an A cell happen and then they'll have a drop. They'll come back up and they'll have another shoulder. So they'll have another A cell. So they're kind of compensating for what just happened. And then they'll go back to baseline. So again, our veal chop, variables, cord compression, earliest head compression, A cells are A-okay. We got good O2. Late is that placental utero insufficiency. So another pattern you could possibly see is called the sinusoidal pattern. And this is a sideline S shape, okay? There are a few instances to where you can have what's called a pseudo-sinusoidal pattern, and this again can happen with Demerol. So if you give Demerol, you can actually cause a pseudosinusoidal pattern. So again, I know I caused it, or Fetal. But a sinusoidal pattern looks like this. It looks like it sounds, sinusoidal. It's an S shape. Okay. So it just depends, because see, if it's fetal anemia, I mean, we could do the big five, but it's not going to really change anything because it's fetal anemia. But if it's an umbilical cord occlusion, then yes, our big five is going to help, hopefully, with changing position. Okay. If it's a CNS malformation, not much I'm going to be able to do for it. Okay. I can't fix that central nervous system. Okay. I will have to be aware then of what type of medications we give mom, because we don't want to further suppress that CNS of baby. Okay.
Or check this one, or vag check this one.
Yes, if you go in and you have a sinusoidal pattern, you might want to assess to see if you have a cord there. Okay.
So a cord can cause this.
If you have an umbilical cord occlusion. But it doesn't necessarily need the cords out. It could be like pressed between the head and the uterine wall.
Occlusion just means prolapse.
Well, it just means that it's cut off. Think about occlusion. When you occlude something, flow, blood flow, water flow, whatever stops. Okay. Huh? Oh, did you have hand presentation? Yep, that happens sometimes.
With the umbilical cord one, you wouldn't check the cervix, like, because you.
I mean, you could. I mean, you're going to do all your interventions to see how could you potentially fix it. But if you do your interventions like changing position, you don't feel a cord, but it's still going on, you didn't give Demerol, you didn't give Fetal, then we know more than likely there's a different cause that we're not going to be able to fix till baby's born. And even then, we may not be able to fix it because of its central nervous system, you know. And so it's going to be that S-shaped sinusoidal. When you say sinusoidal, you have lots of S sounds with an S shape. Okay, side S shape.
So it can really just be benign, or
If it's a true sinusoidal, no, there's something bad. If it's a pseudo, like you haven't seen any of it until you give Demerol or Fetal, and then you have it, and you're like, oh, it's just the Demerol I gave. But if it's, then something's wrong.
Opt for a C-section.
Yes, most of the time with a sinusoidal pattern, something's wrong. We got to get baby out. Yep. Because think fetal anemia. What could that be an indication of? Could be sickle cell, but what's something immediate that could happen that could cause fetal anemia? Placental abruption. If that placenta is pulling away and baby's bleeding out inside the uterine cavity, and all of a sudden you've had this good, happy baby, and now you have this sinusoidal pattern, you could have an abruption going on. Baby's losing blood, so now we have fetal anemia causing it. CNS, that's going to be something that, who knows, you know, but we do need to deliver baby because we got to figure out what's going on.
We don't want to know what baby has to do. Like, if we see those, like, we wouldn't hurry.
We're not going to know. Hopefully there's going to be other signs on my fetal monitor strip that's going to kind of make me aware. So with a placental abruption, sometimes you will have, mom will have that rigid abdomen and pain. Okay, you're not always going to see bleeding, but you will see the rigid abdomen and you may see pain. So you're going to have some other indicators of that abruption, especially if baby's losing enough blood to have fetal anemia. Any questions? So on your simulation, so we have a group today and tomorrow and one next week on Tuesday. Your first few minutes, like 30 minutes to 45 minutes, you have a worksheet that you're going to do. That's why I want you to bring your book. Okay. It's going to go over preeclampsia, medications related to it. And then our simulation is going to be a preeclamptic patient. Okay. So that's why I want you to do that worksheet. So you have it fresh on your brain. You have the policies from Southwest Med for MAG, for Pitocin induction that are in that module. And so you'll be able to open those and read them. I want you to use that for your administration of MAG, what your dose will be. Okay, use Southwest Med protocol, not online. And so you're going to go through that for the first 45 minutes while I finish setting up the simulation. And then we'll break up into two groups and come in and do simulation. You do have an ATI and I think one other thing assigned to do in that time while your group's in simulation, okay? If I haven't emailed individuals yet, but just look back at your grades, okay? If you have a 0 and it's a clinical grade, I have to have it turned in. I did change a lot of dates around, so I'm not gonna give you a 0, okay? I'm gonna give you the points. So, but I just need them turned in, because if I have a blank spot and it's a clinical grade, technically you don't pass your clinical, okay? So just look back and see, you're like, oh, I thought I turned that in. Maybe it didn't upload, okay? Sometimes that happens, but just double check, look at your grade book. If you see a 0, get that stuff turned in to me, okay?
You want me to turn it in?
No, I got it. I already changed it.
So we have the groups today, tomorrow. The Sims.
Yeah, group 2's today, group 1's tomorrow, group 3 is next Tuesday. So,
Tuesday or Wednesday? Today's Wednesday.
oh, Wednesday, it is Wednesday, thank you. And on Wednesday, if you guys want to bring snacks to class, because we're gonna go watch a documentary called Twice Born. You want to bring snacks, popcorn, Cokes, chips?
Is the stuff for the simulation gonna be on the exam for Thursday?
Possibly. I would know it.
So would we do the simulation Tuesday instead of Wednesday?
No, we'll do it Wednesday, but you're gonna have all that information, okay? Because I'm gonna give you, you have access to the information already, like the protocols and stuff, they're on there, so you can open and read them. And even if you want to look at the worksheet, you can. But, and most of what is gonna be in the simulation is gonna be on that case study that I'm gonna give you, okay? Because your actual test questions will more so come from lecture today and tomorrow. Case study will kind of go a little bit through the labor process to postpartum. Okay, but you're gonna have the ability to use your resources to figure it out for me. Okay. Well, for what? No, I don't have it out yet. I will have the case study for the test out by Friday by noon. Okay, I'm trying really hard because I'm writing this from scratch, people. Okay, I'm trying to help y'all all out. Okay. So I'm having to use my brain really hard and it's already hurting. So, huh?
Like this lecture was on yesterday's test.
There were a few things on yesterday's test that was similar to this, but we have been talking about fetal monitor strips since pretty much the first lecture. We have. Fetal monitor strips we've touched on every lecture almost. There's been something almost every lecture because we went through the labor process and so. Okay. Done. Y'all can go. I'll see y'all tomorrow and then group that comes back this afternoon, we'll be back at 1 to 3.